So, good morning, good afternoon, and good evening for all the participants from across the globe. Greetings from HCG Cancer Center, Bangalore. Just a brief introduction about HCG Cancer Center. So, our center is based in Bangalore, which is in the southern part of India. So, we are a chain of cancer centers. We have got 26 cancer care centers across India and also have international presence in Africa and Vietnam. So our model of cancer care is the hub and spoke model, which has been published in the Harvard Business School. So we are also into academics we run a clinical fellowship in head and neck surgical oncology and oral oncology for ENT and general surgeons and maxillofacial surgeons, which is accredited by Royal College of Surgeons, England, and Rajiv Gandhi University of Health Sciences, that is our state university. So during these tough times of COVID pandemic, we have been conducting regular academic activities and in the form of webinars, and an extension of this is the continued online medical education series. So we have been conducting minimally invasive head and neck online meetings. The first module was on transoral laser microsurgery, which was co-hosted with Chris O'Brien Cancer Center, Sydney, Australia, which was attended by eminent faculties from Italy as well as Australia. So today we are into the second module of minimally invasive head and neck surgery, mainly touching upon robotic surgery in head and neck as well as endoscopic surgery. So this will happen on today, that is 19th, and the next Sunday on the 26th. So since we have speakers from across the globe to set the to help in accommodating the time zone, we have divided the sessions into two sessions, that is morning between 10 to 12:30 p.m. and evening between 6 to 8:30 p.m. India time. So this meeting is done in collaboration with HCG Academics and Academy of Head Neck Oncology of Karnataka, a state head and neck body. So academic partners of for the event are Journal of Precision Oncology and GHA. And we'd like to thank our association manager, CIM Global, Ms. Anita Priya and team. From the international speakers, we have Professor Tay, Professor Ko, and Professor Kim from South Korea, Professor Holsinger, Professor Magnuson, Professor Duveri, and Ms. Shilpa from the Intuitive Group from USA, Professor Clark and Professor Krishnan from Australia, Professor Dr. Ofo, Professor Pelleri, and Dr. Jay from United Kingdom, Professor Sang from Hong Kong, Professor D. Almeida from Toronto, and Professor Anu Wong, the pioneer transoral surgeon from Thailand. So we got eminent national faculty, Dr. Tankappan, Dr. Patel, Dr. Deshpande, Dr. Somshekar, Dr. Nayak, Dr. Rajesh, and Dr. Agarwal will be participating as faculties. So this event wouldn't have been possible without the support and encouragement of my senior colleague, Dr. Vishal Rao and Dr. Ravi Nair. Special thanks to Dr. Vidyadharan, my colleague, who helped us in a great way to conduct this event. We also like to acknowledge Dr. Surendra Dabbas and Dr. Rajiv Sharan to helping us in conducting this event. And also my colleagues, Dr. Anand Subhash, Dr. Shalini, and Dr. Bhargav. So we got a series of talks and videos lined up, as I mentioned, in two sessions, morning and evening sessions today and on the 26th, that is next Sunday. So just a word about our Academy of Head and Neck Oncology of Karnataka. So it's a state body of surgeons, radiation oncologists, medical oncologists, and reconstructive surgeons. So this body is affiliated to Asian Oncology Society. So we got series of benefits for the young head and neck surgeons or ENT or general surgeons who want to learn the art of head and neck surgery. To more information about the academia, you can email us on info@ahnok.org, or visit our website at www.ahnok.org. With this little brief, I would like to hand over the screen to my senior colleague, Dr. Vishal Rao, for the welcome address. Over to you, Vishal, sir.
Thank you, Akshay. I'm just going to quickly share my slide. You know, I thought you stole my presentation. We both had similar slides. So I'm going to skip half of those slides now. I had put a little brief introduction on some of these aspects, but you made my life much easier now. So here we are. I'm going to share this. Okay, here we are. So first of all, very good morning to all of you, sir. At the outset, I would like to thank all the eminent international faculty who have spared their time this Sunday. I think, like Akshay said, it's morning, evening, or night, but it's all a Sunday here. So we've all, sorry, I'm just going to resume. Okay. So we've all gathered today for this entire session. And I'm so glad to see all the global faculty from across and all the eminent faculty to come together. Quickly, just to, without much ado, give a little brief introduction. I must congratulate Akshay for all the efforts that he has put in through these weeks. So when he initially proposed this entire idea, the question was, the last 3 months has been extremely heavy on all of us. And we thought, how can we be productive in this time of Corona? And what is it that we could do to keep ourselves engaged? And one of the things from the academics we thought was to create the continued online medical education. And as he rightly said, all of the experts came together to bring and put these COMeD series. So right now we're currently running programs on thyroids, programs on neck dissection, on oral cancers, and guest lectures across, which regularly is being conducted. We are also going to be archiving them in the YouTube so that if anybody wants to go back and listen to these lectures, we've got a very good repository of these materials compiled together, which Akshay has put in efforts for. And that, I think, is the true team spirit that he has displayed here. He and Dr. Shalini and Dr. Anand, they've all put a lot of efforts. Anand, Dr. Bhargav has been a coordinating point for all the, he's our Zoom guru here. So like Akshay said, in addition to these programs, I would also give a little brief introduction to the nature master classes that we're conducting. So if anybody is interested, you can reach out to Akshay. So we run a joint program with the Nature Masterclass where we actually give an online course on scientific writing and publishing, wherein 36 of the nature editors come together to actually teach through 11-hour online course on how to be productive, how do you write good papers. So it's a very nice compendium and it's a certified course. So if anybody is interested from HCG Academics, we are offering this as a free course now during this COVID pandemic, just to encourage youngsters, students to be productive, to write papers and not get bogged down by the current pandemic crisis, which has led to this chaos. I think the other thing that I wanted to share, I think we are at a very interesting time in technological advances, and Dr. Kaustubh is going to open the entire session. Akshay is going to introduce him. Dr. Kaustubh has been a pillar of support. He's been one of the directors of ASTA and HCG. And as we go open into the technological front, Kaustubh sir is going to explain to us the entire thing from past to future. On a lighter note, I thought, from our medical point of view, we are getting more and more embraced with technology. And today, our concept of medical deep learning would be something like this, because that's what we did all our years of studies through a decade and a half. So with this entire thing, I'm going to open the session and thank all the faculty who have spared their time, their valuable time, for giving this platform a meaningful structure. I'll give this over to Akshay again to start the sessions. I just want to also share that we've just initiated the Journal of Precision Oncology, and I would encourage all the people, experts here, if they're interested. This is a joint initiative with Walter Kluwer. Please feel free to send your articles, your expertise, so that we'll be happy to accommodate some of these articles into our journals also and get it published. So Akshay, you can take this lead and coordinate this effort here. Okay. Thank you very much.
Thank you, sir. Over to Dr. Joshna, our fellow, to briefly introduce all the speakers for the session today. Over to Joshna. Joshna, go ahead. Joshna, unmute yourself, unmute.
Sorry about that. So I'll be introducing the speakers for today. Welcome to Minimally Invasive Head and Neck Surgery, module Robotic Surgery of Head and Neck. So firstly, we have Dr. Kaustup Patel. He is a professor, senior head and neck cancer surgeon, and director and founder member of ASTA Oncology Associate Members at HCG Cancer Center, Ahmedabad, India. He is also the founder secretary of Gujarat Society of Head and Neck Oncology and is the past president of FHNO, which is a National Society of Head and Neck Cancer Specialists. He is currently the chairman of Structured Fellowship Program of FHNO across India. He is also a professor and guide for DNB Surgical Oncology Program. He has published 2 books and has over 24 publications in peer-reviewed national and international journals. So he will be talking to us from 10 till 10:30 a.m. So next we have Dr. Vishal Rao. Dr. Vishal Rao, who is presently the regional director at Head and Neck Surgical Oncology and the Associate Dean for the Center of Academic Research at Healthcare Global Cancer Center, Bangalore. Next, we have Dr. Akshay Kudpaje, our Senior Consultant and Program Director of Division of Minimally Invasive Head and Neck Surgery, HCG Center, Bangalore. Next, we have Dr. S. Vidyadharan, who is a Senior Consultant in Head and Neck Surgery Oncology Department at Apollo Proton Cancer Center, Chennai. He also serves as adjunct faculty in Head and Neck Surgical Oncology at Amrita Institute of Medical Sciences, Kochi. We also have Dr. Suren Krishnan, who is Chairman and Clinical Associate Professor of Department of Otorhinolaryngology and Head and Neck Surgery at Royal Adelaide Hospital, University of Adelaide. We have Dr. Raymond Sang. Currently, he is a Clinical Assistant Professor in the Department of Surgery at University of Hong Kong. He also heads the Division of ENT of Department of Surgery at the University of Hong Kong Shenzhen Hospital in Shenzhen, China. We have an eminent surgeon, that is Dr. Kyun Tae, professor at the Department of Otorhinolaryngology in Head and Neck Surgery Department, College of Medicine, Hanyang University, Seoul, Korea. He's also the director at Hanyang University Hospital Cancer Center, Seoul, Korea Secretary General, Asia Pacific Society of Thyroid Surgery. Next, we have Professor Angkun Anwong. He is the pioneer in transoral endoscopic thyroidectomy and parathyroidectomy. He serves as laparoscopic surgeon and also the program director in Minimally Invasive Surgery Division, Department of the Surgery, Police General Hospital, Bangkok, Thailand. To start this all, Dr. Anand Subhash, who will be moderating all the sessions in the morning session, that is, he is a consultant head and neck surgeon at HCG Cancer Center and Trustwell Hospital, Bangalore. Thank you. This is with the introduction of the speakers for the morning session. Now over to you, Dr. Anand, sir.
Thank you, Joshna. I welcome all participants on board for this webinar. This COVID pandemic has been tough for us. Social distancing has been a norm, but I believe what this pandemic has done is brought in or drawn in all of us professionally closer, and academically we've been able to achieve. It's become a true global village now. So we have faculties from across the globe, coming together to talk on robotic surgery and minimally invasive surgery. I'd first welcome Dr. Kaustup Patel for the keynote address on robotic head and neck surgery, the history, technical evolution, and future.
Thank you, Anand. Am I audible?
Yes, sir.
Would like to share my screen. Are you able to see my screen?
Not the presentation, sir.
Okay. Is it on now?
Yes, sir.
Okay, fine. So at the outset, let me thank Vishal, Akshay, Ravi, and the entire team at HCG Bangalore, as well as the Academy of Head and Neck Oncology, Karnataka, for arriving at an excellent program for robotics in head and neck surgery. As you know, you see my topic of this address is history, technical evolution of robotics, head and neck robotics in particular, and future expectations. If we talk about the robotics, it starts with Leonardo da Vinci in 1495, and it also, you know, continues currently with Da Vinci in 2020. So in 1495, Leonardo da Vinci designed the first Robo. He didn't coin the name as Robo, but that was the known first robotic at that, in the history we can date back to. It was a mechanical armored knight to entertain the royalty, and we can see it at Museo Firenze at Florence. In 1921, after so many years, Mr. Carrel, who was an author, Zach author, who coined the word robo from the Zach word robota meaning slave labor. And his science fiction, Rosam's Universal Robo, scared people because in that was the first robotic story and drama also played on that, which, in which the Universal Robo took control over humans. And then the story continued. Isaac Asimov's I, Robot, Star Wars, George Lucas's, and Terminator series, and many more continued in the science fiction stories to scare people or to make people understand that Robo can be helpful. To me, I think there is no such thing as science fiction. It's only scientific eventuality. You know, there is a time when it happens. And surgical robots can then be viewed as extending or enhancing human capabilities rather than replacing humans, in contrast to the example of industrial automation. Robotics per se started in medical practice since 1985 to present days. And the first robotic assisted surgery was done in 1988 by Puma 560 Robo, which was a robotic arm guided laser needle for stereotactic brain surgery. And then at Guy's Hospital, first robotic urological surgery, TURP was done. Then Robodoc came for orthopedic hip surgery in 1992. ESOP developed automated endoscopic systems for optimal positioning and a voice activated robotic arm, and first approved surgical robotic system by FDA. ESOP also developed facilities for telemedicine. Zeus marketed in 1998, and then came Davinci, initially developed by US Department of Defense in 1991. Intuitive Surgical acquired the prototype and commercialized the systems, which was approved by FDA in July 2000. So Da Vinci robotic system is the widely used robotic system right now in the world. And if we say that what are the advantages at present of this system are manifold. There is an image magnification about 10 to 12 times. There is a superior depth perception that is at 3D HD view. Precise tissue manipulation is there. No line of sight limitations, 7-degree functions, tremor filtering, and motion scaling, including the telesurgery. And Davinci technology also evolved over a time. The initial 1999 generation 1 model has reached to a single port system in 2019 and 20. Basically, the dexterity enhancement is one of the major advantage by robotic systems. They are accurate, precise, untiring. It can be smaller or larger. It can be remotely operated. It is connected to computers and not always able to operate autonomously in high complex uncertain environment. And that's why human beings are needed. There is a great binocular 3D vision. There are ultra small forceps and many other equipments, arms, which have been developed for specific surgeries. And the scaling of the human motion is one of the major advantage for a small cavity like oropharynx or supraglottic region. So how TORS developed and why TORS developed? There is a historical perspective to this. This is not a shifting paradigm, but this is a revolving paradigm. If you see this chart, you'll be able to see that in 80s, surgery followed by adjuvant radiation was the norm compared to primary radiotherapy, and both were practiced for oropharyngeal cancers. In late 90s, transoral laser microsurgery for tonsil-based tongue and supraglottic region became possible and popularized. At the same time, chemoradiotherapy came into the picture, and IMRT also improved radiation deliveries. And it was a time around 2006 that the TORS came into picture. Now, TORS was a game changer for HPV positive patients in Western world because of the de-intensification therapy. And we will discuss that in a while now. Open surgery, chemoradiation, TORS, and then robotic surgery. So, the first, why it came. So chemoradiation started becoming a norm for oropharyngeal cancers, but then the several articles started coming up for the complications of chemoradiations or late sequelae of chemoradiation, like feeding tube neutropenia, dysphagia related issues, and things like that. That started the world to think about bringing surgery back. But surgery traditionally was biomandibulotomy and transpharyngeal surgery with increased functional morbidities, especially when was combined with postoperative radiation or chemoradiation. So in past 2 decades, TORS with lesser morbidity started coming up as an option, and oncological and functional outcomes have compared favorably with standard treatments. The beginning was at University of Pennsylvania by Bert O'Malley and Greg Weinstein, who described their tongue base and tonsil resections. And at Mount Sinai also, Dr. Gordon Jenden started doing surgeries and publicizing their results. The advantage was 3D optics, 4-hand surgeries, which allowed a surgeon at the bedside using his 2 arms and robotic 2 arms used with cautery, made better visualization, and it avoided complication during and after surgery. So, and then this started getting published, which came with FDA approval in 2009 for T1, T2 oropharyngeal cancers, malignant as well as benign tumors. With this, there was a flurry of literature, multi-center studies to assess feasibility, safety, and surgical margins. There were many articles of functional outcomes, which was favorable. And then there were many multi-institutional studies, which also described oncological outcomes in different journals. And this paved the way to establishing robotic surgery in HPV positive patients. Now in India, Dr. Dabas, Dr. Karan and his group started publishing their results with HPV negative patients. And it was a huge trial which showed that there is a 89% overall survival and 93.8% median follow-up at 29 months. So this started giving us a vision that there is a possibility of establishing this in HPV negative also. ECOG 3311 study for P16 de-intensification regime in ASCO 2020 established its role. What we feel at India, that when we have 80% of HPV negative patients in oropharyngeal group, this was one study which could have been started in India, where in Western world they could not enroll patients, and because of that this study comparing the TORS versus chemoradiation was stopped. So basically the evolution of robotic system from 2000 to flex robotic systems and single port systems in 2019-20 is the journey which established TORS as an option for head and neck surgery. Today, limited pharyngectomy, partial glossectomy, supraglottic laryngectomy, total laryngectomy, hypopharyngectomy, parapharyngeal space surgeries, nasopharyngectomy, Zenker's repair, neck dissection, thyroidectomy, submandibular gland excisions, and microvascular reconstructions are the areas where TORS is getting established at different centers in the world. Robotic thyroid surgery needs a very special mention because that was developed more in Korea and Eastern hemisphere, where these approaches got established, and we have this option, and we are going to hear a lot about this during these sessions. And then new companies started coming into this, and fortunately we can see on horizon other systems, other computerized robotic systems which can give us an option to Davinci, and maybe in time to come we will have a plethora of systems to choose from, and then that will make the systems probably more acceptable. iSnake from Imperial College, Med Robotics Flex system, which is getting established now, Medtronic surgical robo, and Johnson & Johnson developing with Google that surgical robo. Essentially, the quest is to improve on human limitations, to improve on robotic limitation, and to transfer the human strength to robotic strengths. And that is what is probably going to see the robotic future in time to come. So what is the need of an hour? Slender instruments are what head and neck surgeons need in oropharynx. XI system has that limitation of having a bigger instruments, which was not there with SI system. But XI is a better system than SI. So, we need slender instruments with our systems. Haptic feedback is still not there. Image guidance can give us quite a lot of advantage in nasopharynx and skull-based development. Augmented reality, real-time histology, fluorescence signature, Autobots being developed by our reliable telesurgical capabilities, compatibility with available medical equipment, and standardizing like laser and other things can be become compatible with the robotic systems. In nutshell, a safe, extremely efficient, easy sterilizable, cheap and compact robot is the need of an hour. We see in airline industry autopilots. This has been there since years. We have seen driverless Google car getting, a norm at many places. So why not autonomous robot surgeons? The technologies have changed the future of many sectors. But if we go according to the sector, that the change in technology has brought change in future of business at society level also, but in healthcare it is very slow. And why is that so? Because healthcare deals with human beings, and the most challenging moral and ethical implications come when you are dealing with human beings. This is what I can remember as my first day when Davinci XI was installed at our center. My daughter was so happy knowing that news, and she told me that, Dad, now with Robo with you, you will be able to attend all my football, matches, and you will be there to see me performing. Unfortunately, this has not happened. And she said now she's in college and her major is literature. So I now explained her that you read Isaac Asimov's Complete Robo and you will be able to see the 3 rules of robotics. Whenever this is there will be a time when I will always be able to reach wherever I want. A robo may not injure a human being or through inaction allow one to come to harm. Second rule is robo must obey all orders given to it from humans, except where such orders would contradict the first law. And the third law is a robot must protect its own existence, except when to do so would contradict the first law or the second law. With this, I would like to end my address and I'm happy to take questions. Thank you.
Thank you, sir. Thanks for that wonderful presentation and taking us through the evolution where we were and how we have progressed and what the future would look like. Thank you for giving us a glimpse into the future, sir. Sir, we would be moving forward and we'll be taking the questions later on, sir. So for the next session, sir.
Okay.
You can pitch in whenever there is a question.
Okay. Thank you.
So for next, we have a talk on contemporary surgery to robotic surgery. What's the evolution by Dr. Vishal Rao.
Can I share the slides?
Yes.
Just one second. Are you able to see the slides?
Yes.
I think that was a very lucid presentation by sir. So I think the very interesting message which he gave, I thought this was a very interesting blend of philosophy and science that he gave together on the introduction of it. One of the things that I'm reminded of is we were at a panel discussion with a group of Stanford engineers, where one of the engineers very strongly in that forum said that give us 10 years and we'll make doctors redundant. It was a very nice point that he made very strongly, very, very fervently. And at the end of it, I was one of the people who supported him and told him, there was a lot of discussion on this. There was a lot of debate and a lot of disagreement. But one of the things I enjoyed discussing, I told him on a lighter note that to this engineer, that look, 10 years from now, maybe MCH will go away and MTech will come over in oncology. But we will still be there. We will still be working together, and you will not be able to replace anything. because finally we are going to be dealing with humans, and humans need an interaction. So no matter what amount of advanced technologies and replacements we work for, maybe MCH will turn to MTech in oncology, and eventually we will all be there, but we will need to reinvent the wheel. And the classic example, what Kaustubh sir said, he's seen the entire generation pass by from open surgery to now coming to robotics. So I think I'm going to try and avoid overlaps from what he has spoken, because he summarized it very beautifully, but I'm going to try and fill in some of those gaps in this evolution in the next coming slides. Now, what I intend to speak in this entire coming minutes is that I'm going to talk a little bit about technological advances and how it has been used to bridge biological advances in the evolution of contemporary surgery to robotics. So I'm going to talk a little bit in the introduction about artificial intelligence versus natural stupidity, how MD and machines can interface, and towards the end talk about actually the transition and the advantages of robotics from contemporary surgery. So this is a very interesting paper that got published in the commentary section by Barbara Stryfield from the John Hopkins team in US, which actually was talking about is US healthcare, one of the best healthcare systems in the world. The important message in this was when they looked at mortality among the group of people, and they looked at which are the top causes of mortality. The interesting things that they shared there was that cardiovascular diseases was number 1, cancer was number 2, and guess what was number 3? It was a doctor. So they showed this particular data where there was 12,000 unnecessary surgeries, 7,000 medication errors, 20,000 other errors, 80,000 infections, 1 lakh non-negative effect of drugs, a total of 250,000 deaths per year from iatrogenic causes. Anyway, that was just kind of a platform for us to talk about, saying that machines entered to reduce errors. Machines were brought in to actually reduce errors and improve efficacy, like what Kaustubh sir said. And that's been one of the main entry points for machine to say that they can behave better than humans in terms of accuracy. They can actually create a more streamlined process, and that way they are able to overcome the inefficiency or the limitations what people can give by training these machines in a better way. So, over the last few years, there's been a lot of interest on this, and this is one of the articles that I would urge all of you to read. This article was published by the Lancet Oncology Commission, which talked about the future of cancer research in US, but actually puts together a lot of philosophies which the Blue Ribbon panel gave in 2016, funded by Joe Biden at that time, who was the vice president, who put a lot of focus in oncology, in cancer. Now, there were a lot of recommendations. This is a very large paper, but worth a read to look at. What did they want to look at? They wanted to look at funding all the futuristic work, all the important work across the globe, and look at how can we create a larger vision for oncology and fund research, which is vital. So there were important messages out of this. I'm not going to go into the details of this paper, but what I want to introduce through this thing was they created the cancer moonshot, in which they looked at 5 priorities for cancer moonshot. So this cancer moonshot philosophy, what they said was looking at the future of cancer treatments for the world, had 5 important points, among which the number 1 was enabling technologies, second one was immunotherapy, third one was precision medicine, fourth was personalized medicine, and fifth is big data. And I want especially our youngsters, fellows, and researchers to look at this more seriously, because the next 10 years will see a steep rise in these 5 areas. And it is for us right now to start beginning our work and getting familiar with these territories in a big way. So if you look at health 2.0, now industry today is at 4.0 version, whereas health is still at 2.0. We're always about 2 versions behind compared to that of technology and industry, because somewhere in healthcare system, like Dr. Kaustubh said, see, we have a bigger important thing that we go through a comprehensive education, we go through a detailed education, we learn something, and it becomes very difficult for us to unlearn it, because unlearning that and adopting a new technology may alter our results. One, it can add to further costs. So these are the 2 reasons why physicians, surgeons hesitate to adopt new technologies very easily. But if you look at the health 2.0 now, that is going to be defined, there are 12 areas which are going to be important game changers for the future. Digital diagnostics, IoTs, ultra-fast scanners, wearables, blockchains, digital therapies, big data, nano health, AI, hackathons, system learning, and robotics. Now, if you see these 12 areas, I've highlighted 3 of them. These are going to be crucial. I'm highlighting these 3 because these 3 are some of the key focuses of our talk today. This is going to be a very, very important benchmark for us to put this discussion in perspective. Now, if you look at the first ever discussion that took place on this was when the IBM Watson won the Jeopardy competition in the TV quiz in February 2011. Now, that's when the global attention came out to actually speaking about the capabilities. You can see the Watson winning the thing against 2 top intellectuals who have been consistently winning that game. So Watson won this quiz, and that's when they realized that machines can outperform humans in many areas. And a lot of it, and I'm talking about robotics, but I have to tell you that it's been an integral part of artificial intelligence, that robotics and artificial intelligence have a crosstalk. And that's where I'm going to introduce both the topics together, because before we jump into robotics, let's understand how did this robotics evolve. So if you look at the invention of the modern computer in the 40s, to birth of AI in 56, to the emergence of robotics way back in 1970. If you see the timelines of this has been a very systematic timeline evolution, and AI seems to be one of the foundations of robotics, because artificial intelligence systems are desperately required and form a very important base of robotic systems. Now, I just want to explain to you, I don't intend to make you engineers through this, but I think what is very important to understand through this entire evolution is AI is a very key of understanding if you want to understand robotics. And this is important because I believe that the future of a few surgeons will be to also develop such robots. You will be sitting in panels with Google or with Davinci or with any other such companies who are going to be actually framing robots which are going to be more intelligent, where they will require surgical input. So you will need to have a little basics about artificial intelligence for your understanding. Now, what's important for us to know is that there are 3 proper headings under which you need to study AI, artificial intelligence. There are stages, there are types, and there are domains for artificial intelligence. What's important is the stages. We have the artificial narrow intelligence, then we have the general intelligence and super intelligence. That's the evolution of the stages from stage 1 to stage 3. Currently, we are at narrow intelligence stage. In terms of types of artificial intelligence, you see there is reactive machine learnings using AI, then there's limited memory AI and theory of mind and self-aware AI. We are still not reached 2, 3, 4. We are still at number 1, which is reactive machine AI. And if you look at domains, there have been several domains in which artificial intelligence have been looked at. Each one of these domains are actually independent entities by themselves, whether it's machine learning, deep learning, natural language processing, robotics, fuzzy logics, or expert systems. Now, why I'm explaining this to you is, here we are focusing on number 4 with number 1 and number 1. And that's the area which we are focusing today. But what we are going to be eventually reaching, like what Dr. Kaustubh Patel spoke about in terms, is we are going over here. And that's when a lot of philosophers are getting worried. A lot of scientists are getting overtly concerned to say that if it evolves here, what is it going to be that we are going to be doing? And that's what I'm going to talk to you a little about. So if you see artificial intelligence version 1 in healthcare, you will see that you are using it for managing health records and data, doing repetitive jobs, treatment designs, digital consultation, virtual nurses, medication management, drug creations, precision medicine, health monitoring, and health system analysis. And robotics are going to be cross-talking with each one of these. So we are currently working at HCG with a group of robotic experts who are creating it beyond the spectrum of just surgery alone to look at human interfaces at various time points. But again, unfortunately, we are just here. That is at artificial narrow intelligence with reactive machine AI, which means we are just going to look at master-slave systems. Now, what do? They do decision-making, they solve complex problems, they can perform high computational level computations and increased accuracy. Now, what's important for us to know is that the current systems that we use, like Alexa, Siri, these are all systems that we are doing with artificial narrow intelligence and reactive machine AIs. So our Siris, our Alexa are all systems that are built on natural intelligence and reactive machine AIs. But where we are going to reach under the same headings, which I spoke earlier, is we are moving towards general intelligence. We are moving towards artificial super intelligence using the stages of using the types of limited memory AI, theory of mind, and self-aware AI. Now we've already touched here with the self-monitored cars. The driverless cars have slowly moved towards limited memory AI, which means they are able to take certain independent decisions. They are able to take right now. Now that's where Stephen Hawking once said that the fear is that when it moves towards theory of mind, these robots are going to become so intelligent that they may overtake humankind. And that's something like Dr. Kaustubh again said very beautifully. There is no sci-fi. We are processing evolution here. But that having said done, today we are clearly seeing that there is a very stark difference between artificial intelligence versus natural stupidity. You cannot have natural stupidity replace artificial intelligence, and our robots are classically an example of that because they believe on a lot of data reliability. So if you look at the introduction of robotic surgeries for our fields, you know, it came in because of the interest for organ preservation. Now, initially in the 90s, when we spoke about organ preservation, it was presumed that it is non-surgical. Today, we've evolved towards saying that organ preservation need not be only surgical, but need not be only non-surgical, but also can be surgical. And the principle of that being an organ preserved should be an organ functional. Now, why is this important? Because at the end of me giving chemoradiotherapy to the oropharynx, if the organ is dysfunctional, and then it defeats the purpose. The same way it is for a laryngeal, because which got popular with organ preservation. If the laryngeal area is continuing to have aspiration, if there is dysphagia, then we have defeated the purposes of organ preservation because it's not a functional organ. So with that background, we've seen a very nice evolution from contemporary surgery where we did it intraorally to in open procedures to where our robots were washing up, you know, and you're sitting on a corner now with a cup of coffee, but you will be able to monitor the machine in a better way, in a very precise way. So the earliest evolutions that came into the market, and I'm giving Davinci as an expert model here because Davinci is the one successful model that has shown, I think if you see the way back publications that were there in 2016 showed that they had about 3,500 odd robots which were deputed across the world in more than 500 odd centers. To today, they must have expanded it much better. I'm sure it must have crossed double that number. So now the question is that they have been used from the timelines of 1999 to the current systems that they've built. They've themselves go through an evolution, which is being used in cardiac, colorectal, general surgeries, gynecological surgeries, head and neck, thoracic, and urology. This is in the alphabetical order that I'm mentioning it. Now, this is very crucial for us to understand that the evolution of these robots happened along with a lot new amount of technologies that they added in, again, which Dr. Kaustubh alluded to earlier, which had advanced energy system, endorest, integrated table motion, Firefly, they had single site technology, simulations and analytics. So a lot amount of interesting aspects have gone in to the entire technological advancements. But what is important for us to understand is three important aspects. There are three components to the robot. The surgeon's console, which is also called the master console. We call it the 3Ms. You have the robotic machine with the arms, and you have the vision console. So you have three aspects to this entire thing that we are able to have. Now, just remember the rule of three, that there are three components, there are three arms, and there are three key features. Now, when we talked about the three components that I talked about are the surgeon's console or the master console, the robot machine with the mobile arm. So it's the mobile platform with the robotic arms, and it's the vision control with the monitors. So it's called the monitor cart. So these are the three components that we have, the 3 Ms. Then we have the 3 arms. in addition to the camera, I have not put camera as the arm, and then we have three important key features. Now, what are the three important key features in this? The three important key features that we have in a robot are location triangulations, user control dexterity, and instrument sensory feedbacks. These are some of the key things which I'm highlighting from a perspective of the most commonly used robot, which is the Davinci robot. So location wise, the triangulation, user control dexterity, and instrument sensory feedbacks are very, very crucial three features that we need to recognize. Now, as Dr. Kaustubh again said earlier, the desirable for us is like this monkey. We need, all surgeons want to have big eyes and small hands. So this is a classic example where if we are able to conquer the limitations of space and time for us, so we are able to achieve this goal where we are going to be able to reach with smaller hands and bigger eyes with better visualizations and achieve better results is one of the things that man has been working on, and technology has come to aid in this. The second thing in terms of our importance is that the 10 most important instruments for a surgeon are his 10 fingers. So we are not able to reach several times into these areas because we are not able to get the ideal visualization and have smaller hands. And that is what the robot complements us, that it gives us these important things. So today we have digital haptic instrumentation that has been integrated into robotic systems. So if you see the types of haptic systems, there is graspable system which our robots use, then there are wearables and touchables which are used in various other technologies. But what's important for us to know is that graspable haptics are being used currently in Davinci robots, and this instruments basically works on the principles that it uses the distal ends of your instruments to give you digital feedback mechanism. So how they do it is that the stimuli, when you touch the digital part of the end, it is able to process certain signal and give you certain neural transmissions based on your sensory receptors. So that is what is the principle of this particular mechanism. So when you hold your finger on the robotic manipulators, the telemanipulators, that is when you are getting some amount of feedbacks based on the graspable haptic systems. The other very important feature that has been added into the robots is the Endotracheal, which is a patent technology by Davinci, wherein there are two important components in the master console. One is that there is something called as degree of freedom in the arm, which is in the surgeon's robotic arm, which has 3 degrees of freedom. And in the instrument's arm, there is another 7 degrees of freedom, which is added, which we have shown over here in this picture. So these are some of the technological advances that kind of replicates what we call this is called the biomimicry. What we do in biomimicry is that we try to replicate human interfaces as though it's mimicking the same picture. The other aspect is looking at telemanipulation and tremor filtration. So if you see this, the main aspect of this has been to look at telemanipulations and tremor filtrations using these haptic endoverse feedback mechanisms. So again, the goal of all these technologies has been to improve outcomes. The surgeon experience and ease has to be better, reducing infections and readmissions, length of stay post-operatively, and improving the cost-benefit ratio. The larger question that remains unanswered to us is, have we achieved these 4 or 5 objectives? The question right now is, the answer is no, not fully. But yes, this is a process in evolution. But the larger goals remain under these broad headings of to improve outcomes, improve experience, reduce infections and readmissions, length of stay, and improve costs. How much have we received in this entire area is, again, like I told you, a process that we yet need to witness. But like Dr. Kaustubh said, there are more than 15 to 18 groups that have already entered the market with robots. So Davinci tops the list, but we have a whole list of them that is available today, which have each got some patents, some technological advances, and there are groups in India that have been currently also working on developing their own robots. So the current robot that we have is a master-slave system. I am again not going to go into the details of this, but we've published some of our work. We've got a couple of papers that we've published using some of the modified techniques on this. We've made our own retractors, which is there for robotic neck dissection. We've made the modified facelift approach. This is a published work that we did. We recently published another paper on how to raise a retroauricular flaps. So from our point of view, we've been doing some aspect of the academics. I'm again not going to go into the depths of this, but this is a patient of ours who required a posterior segmental mandibulectomy, tonsillectomy, palatectomy, pharyngectomy, base tongue resection with free fibula. Now the entire approach was done with a combined facelift and TORS approach with retroauricular neck dissection. And this was his day 14 post-op. The point I want to make is that we can evolve to this in select number of cases. I'm not saying in every number of cases. These patients were paranoid for cosmetics, and in them we were able to give a controlled margin with decent results. This is a patient who underwent a palatectomy for a low-grade carcinoma of the palate. He was a young techie and did not want a scar, and we were able to do a retroauricular neck dissection. Dr. Surendra Dabbas has been our guru in this. He's taken a lot of efforts and pains to come forward, train us, teach us in this, and we've been able to achieve some of these goals now. So we've evolved over the process. I'm going to skip some of these, but this was just one simple case that where we used interventional radiology and embolizations with lingual artery to actually do robotics together, because the lesion was a central base tongue lesion that we had. And the question was, can we remove this lesion without actually destroying the tongue base? So we actually were able to do this with posterior lingual arterial embolization and entirely resecting the specimen using the principles of embolization with our interventional radiology. And we were able to decannulate the patient on day 7 and achieve a good result in this group of patients. The point I wanted to mention was, in this patient, a conventional treatment that was offered was base tongue resection with supraglottic laryngectomy, and he was able to get away with a good margin clearance of robotic dissection with base tongue because of arterial embolization of the lingual artery posterior. And this was 7 months later, where he came to us for a follow-up. Even on day 7, we were able to save his tongue. He was able to maintain mobility, and he's now back on track with his with his regular deglutition without aspiration. This is his new pseudovalvular that was formed there, and you're seeing that the vocal cords and the things did not show any kind of aspiration. So we've also now built our own retractors. We've been working hard to see how can we take this in a more affordable way to the markets, and this is something that's going to take a little longer period, but we built the first prototypes and patented them. So I'm going to leave you all with some final thoughts. There was a very interesting meeting that Einstein and Ravindranath Tagore met, and they both apparently discussed on the concept of his world as a unity dependent on humanity versus world as an independent reality that is independent of the human factor. And this is a very interesting conversation for anybody who was willing to read this. It's a very philosophical conversation, because we are in a time of robots, artificial intelligence. And what Ravindranath Tagore spoke was resonating a lot, saying that all of this of the world's reality would be meaningless without humans. And that is what today even the corona pandemic is teaching us. So how we are going to use these technologies will define if it will help us or kill us. So I'll leave you all with these thoughts. Thank you very much.
Thank you, sir. Thanks for that talk. You have also seen things evolve from the open to the robotics, and as a youngster, the haptic feedback is quite an essential thing for you to feel. So you did touch upon it, but what are your thoughts? How do you overcome this limitation in the current systems?
Sorry, limitation in
the haptic feedback.
So Indian Institute of Science has developed some very good endoscopic techniques with advanced haptics that they're working on, which also, so they actually built this up for training people in endoscopy. So they felt to train people in bronchoscopy, they actually built this entire haptics. But I think these systems have now already come together in a very effective way. You see more and more of these haptic systems that are going to get advanced with technology. And what they are looking at integrating is wearables to improve these experiences further. So I'm sure IoT is going to play a very key role in improving haptic systems here. And that is what Google and a couple of people are already working on. So I'm sure this is going to be something like this, that we are going to have IoTs in a very big way. We are going to have wearables come up in a big way and improve the crosstalk between these devices.
Thank you, sir. Thanks for the talk. I would now move forward to the next talk by Dr. Vidyadharan and Dr. Akshay, which will be on applied anatomy, the surgical considerations in a transoral robotic surgery for both oropharynx and laryngeal surgeries. Over to you.
Hi, Anand, can you hear me?
Yeah.
Oh, okay.
Your presentation is up. Right.
Hello. Yeah. So before I start at the outset, I wanted to thank Professor Vishal Rao, Akshay, Anand, and the rest of the HCD team and the Academy of Hedonic Oncology Karnataka for this opportunity. The robotic surgery is a little bit more deep to my heart amongst all the other surgeries in head and neck. So before, you had a fabulous talk, fabulous thought-provoking talk by the previous two speakers. This talk and the next talk is basically anatomy and basically facts, which may not be that thought-provoking, but very crucial for transoral robotic surgery. It has to lay the foundations for it. So my topic is on the applied anatomy of the oropharynx and surgical consultations. This is where I work. Oh, sorry, Anand, can you are you able to see?
It's not in the PowerPoint mode, the presentation mode.
1 second. Hold on. How about now? Okay?
Yeah.
Okay. Yeah. So I've turned off the video because I have some videos in my talk, so just to help conserve the bandwidth. So this is the hospital where I work. It's the Apollo Proton Cancer Center in Chennai. So coming to oropharynx, the oropharynx is the region of the pharynx between the nasopharynx and the laryngopharynx or the hypopharynx. It extends from the soft palate down to the epiglottis, and it is like a box which opens anteriorly to the oral cavity. Okay, and the oropharynx, as you can see in the picture here, it encompasses the soft palate, the palatine tonsils, and the base of tongue. The boundaries of the oropharynx are the palatine arches and the palatine tonsils laterally. The posterior border of the soft palate superiorly. Inferiorly is the base of the tongue, and posteriorly the posterior pharyngeal wall. And all these structures are covered by stratified squamous epithelium. This is a normal anatomical view, and this is the transoral view, which you have during surgery. Traditionally, as the previous speakers also mentioned, the approaches to malignant tumors of the oropharynx or the paraphernal space ended up violating the anatomy of the oral cavity. And the main reason for this was we needed to see the anatomical structures and to obtain clear margins of the tumor which was there in the oropharynx. However, because of the new natural orifice endoscopic techniques such as transoral robotic surgery, they utilize the oral cavity to directly gain access to the tumor of the oropharynx. Hence, besides having the knowledge of traditional surgical landmarks for open approaches, the robotic surgeon needs to have an in-depth understanding of the anatomy from inside out to safely carry out transoral robotic surgery. So the anatomical considerations for transoral robotic approach can be viewed from a perspective of myofascial layers in the surgical field, that is the muscle and the fascia, and the neurovascular structures that traverse this field. So I'll be focusing mainly on this for this talk. The lateral pharyngeal wall, which is medial and posterior to the retromolar trigonaria and the pterygomandibular raphe, contains the palatine arches or the tonsillar pillars, and they are the mucosa-covered palatoglossus muscle and the palatopharyngeus muscle, which you can see in the video here. This recess, which is produced by these two arches, is the tonsillar fossa, and it contains the palatine tonsil. The palatine tonsil is a lymphoid tissue with lots of crypts in it, and it's situated in the tonsillar fossa, and that's covered by stratified squamous epithelium too. These crypts are said to be the initial site of the human papillomavirus infection going down to the basement membrane. Okay, now this slide shows the axial section of the oropharynx and the paraphernal space. The palatine tonsils, as you can see here, are paired lymphoid organs, and lateral to the tonsil is the tonsillar capsule, which is basically the pharyngo-basilar fascia, which envelopes the tonsil, and it also communicates anteriorly to the pterygomandibular raphe. The medial border of the tonsil is free, and immediately lateral to the tonsil, you have the superior constrictor muscle, which extends from one side to the other side. As you zoom in a bit more deeper, you can see that immediately lateral to the superior constrictor muscle is a thin fascia, which is called the buccopharyngeal fascia. And this buccopharyngeal fascia is the final barrier between the tonsillar fossa and the parapharyngeal space. So once you enter the buccopharyngeal fascia, you're entering the medial part of the anteromedial part of the parapharyngeal space. So it's important to know this intimate knowledge for a safe and effective lateral oropharyngectomy or parapharyngeal tumor excision, because this space contains a lot of important neurovascular structures. Now we see in an oblique view, you can see that between the medial pterygoid muscle and the superior constrictor, there is a pad of fat or a fat plane, and this compartment is the pre-styloid, and it contains sometimes some pterygoid venous plexus. During surgery, it's easy to bipolar these vessels, and you can continue with the further dissection. Medial to the medial pterygoid muscle and enveloping these three muscles, which come from the styloid process, that is the stylopharyngeus, stylohyoid, and styloglossus muscles, is a gray thick facial membrane. It's called the styloid diaphragm. And this separates, along with the styloid muscles, separate the parapharyngeal space into this pre-styloid and post-styloid compartment. And the post-styloid compartment has the internal carotid artery, external carotid artery, the internal carotid artery, jugular vein, and the vagus nerve and glossopharyngeal nerve. This is a video which shows the attachment of the pterygomandibular raphe. So on the left-hand side of the screen, you can see where the buccal mucosa would be there, and pterygomandibular raphe. From the raphe, the attachments of the superior constrictor and the pharyngobasilar fascia would start. Here is the posterior view of the oropharynx. It is the majority of the posterior part of oropharynx is by the superior constrictor, and it's overlapped by the middle constrictor muscle. And so the inferior part of the tonsillar fossa would have part of the middle constrictor, but majority of the tonsillar fossa contains the superior constrictor muscle. And lateral to the superior constrictor muscle, you can see the three muscles which are attached to the styloid process. These muscles are the styloid muscles, as I mentioned before, and they are known as the Rayolans bouquet. That's a part of the Rayolans bouquet, which contains ligaments and muscles. It looks like a bouquet of flowers. So the next, coming to the two most important structures, important anatomy of this talk, is the styloglossus muscle and the stylopharyngeus muscle. The styloglossus muscle arises from the inferior aspect of the styloid process, and it kind of broadens as it descends, running deep to the medial pterygoid muscle. You can see the medial pterygoid muscle, and before it starts blending with the fibers of the intrinsic tongue muscles. The adjacent muscle is the stylopharyngeus muscle, and it originates from the medial aspect of the styloid process, courses medial and posterior to the styloglossus muscle, and it runs in between the external and internal carotid artery, and then it fans out and inserts in between the superior and middle constrictor over here. So when we are doing the transverse robotic dissection, you would encounter the styloglossus muscle first. So the neurovascular structures, which I mentioned, the post-styloid space, would be lateral and inferior to the plane of the styloglossus muscle. And so these two muscles represent the deep final boundary of dissection. And beyond that, you have a pad of fat. And you have to keep in mind that the pad of fat, which I showed before, if the patient had undergone radiation therapy, this pad of fat will actually be very thin. So you have to keep in mind when you're dissecting, you're not going to see a lot of fat in a post-radiated patient. Here's another illustration showing the neurovascular bundle, which is inferior and lateral to the styloglossus muscle. There's another one to get you oriented between the styloid muscles and the internal carotid artery, and also the branches of the external carotid artery. This is another oblique anatomical view. Coming to the blood supply of the tonsil, it's mainly supplied by the branches of the facial artery, lingual artery, and ascending pharyngeal artery. Tonsil has 5 blood supplies, and it's very easy to bipolarize or ligate these. Very easy to bipolarize or cauterize these branches, which is very well known for among the ENT surgeons because when they do tonsillectomy. But however, when you go beyond the superior constrictor, these vessels start the lumen of these vessels start getting bigger, and you'll end up seeing the larger branches of these 3 arteries. So there you need to make sure you add Liga clips. And this is a better illustration of the arterial supply of the lateral pharyngeal wall and the base of tongue. And all this is supplied by the branches of the external carotid artery. Hence, if you ever have the unfortunate episode of post-operative bleed and you cannot ligate the vessels or find the bleeder here, you just need to go down, open the neck, and ligate the external carotid artery. That's the final step. Now, it is very important to know that there are some variations of these blood vessels, and we need to have a good understanding of these major arteries in the parapharyngeal space and lateral oropharynx. So one such variation is the variation of the external carotid artery. So I was telling you about the styloid diaphragm, the thin fascia between these 2 muscles, the stylopharyngeal, styloglossus. So if there is a dehiscence between these 2 muscles in the styloid diaphragm, the external carotid artery can bulge and come medially and be close to the superior constrictor. So when you're doing lateral oropharyngectomy, you need to know that beforehand. The other issue is that normally the external carotid artery is about 1.8 centimeters from the lateral pharyngeal wall. Okay, but all these studies, anatomical studies, are done on most of them are done on cadavers. So the exact number may not be accurate, but this is the average distance between the lateral pharyngeal wall and the external carotid artery. In the transoral view, you can see the 2 muscles, styloglossus, stylopharyngeus, and you don't see an external carotid artery here. This is normal view, and over here you can see the external carotid artery. When there is a dehiscence, it bulges in between those 2. This is after you remove the superior constrictor muscle. You should also know there are branching patterns of the ascending pharyngeal artery. That's one big artery which arises from the external carotid most of the time, and it is lateral to the superior constrictor. There is a good paper on that. You can look up the classification. But the most important point I wanted to highlight is that the ascending pharyngeal artery is sometimes known to be a sentinel landmark for the internal carotid artery. If you identify the ascending pharyngeal artery, you can be quite sure that behind the ascending pharyngeal artery, you will find the internal carotid artery. So, and you can be safe. And beyond all these 2, at least 10 to 40% of the general population has some aberration of the internal cervical, internal carotid artery in the parapharyngeal space. And normally, the internal carotid artery lies about 2.1 to 2.5 centimeters from the lateral pharyngeal wall at the level of C2, C3. But sometimes it can be coiled, or there could be a kink, or they could have a tortuous course, and you need to really identify this in the preoperative scans, because if you do end up having to accidentally puncture the artery, you are going to have a very catastrophic bleed. Pfeiffer et al. Has proposed a clinical classification system for aberrant internal carotid artery, and this is mainly in relation to the parapharyngeal part of the internal carotid artery. There are also some reports of the stylopharyngeus muscle compressing the internal carotid artery and causing a bulge into the lateral pharyngeal wall, or going more closer to the superior constrictor muscle. Now, coming to the glossopharyngeal nerve, this nerve, it supplies the stylopharyngeus muscle, and it gives a motor supply for the stylopharyngeus muscle, and it also gives sensation to the oropharynx, and also autonomic innervation to the parotid gland and carotid body. So during the parapharyngeal course of the nerve, it sends branches to the tonsil. So you have tonsillar branches, which will end up resecting during the lateral oropharyngectomy, and also it gives branches to the posterior 1/3 of tongue. And it can be easily identified along the lateral surface of the stylopharyngeus muscle. And it can be also visualized at the intersection where it starts branching to the base of tongue. You can see here epiglottis, base of tongue, and then the glossopharyngeal nerve branching over there. So if you can, if it's not included in the field, sometimes you can preserve some other branches. Now, the tongue is composed of both intrinsic and extrinsic muscles, and the base of the tongue is covered by lymphoid tissue or the lingual tonsil, which may be contiguous to the palatine tonsil at the glossotonsillar sulcus. And below this lingual tissue is the intrinsic muscles of the tongue. This is actually the lingual nerve. And the most important point is the depth of the bony landmark to the base of tongue and the blood vessels which come in between that. So upon removing the lingual tonsil, and if you remove tongue base, the muscles of the tongue base, below that you will encounter the hyoid bone. And above the hyoid bone, the tongue basically derives its blood supply from the lingual artery. And the lingual artery is also a branch of the external carotid artery. And basically it transfers, at the level of the greater cornu, it arises from the external carotid artery. And it goes lateral to the middle constrictor muscle, where it ends up getting crossed by the hypoglossal nerve. And then it passes medial to the hyoglossus muscle. So if you see here in this picture, you can see the hyoglossus muscle. It passes medial to the hyoglossus muscle. And in this location, where there's a chance of you injuring the lingual artery. And when it goes medial to the hyoglossus muscle, it starts supplying the dorsal lingual branches or the dorsal lingual artery branches out from the lingual artery. And this supplies the mucosa of the tongue and the rest of the tongue. And you can see over here is a better illustration of the dorsal lingual artery here. And there's a lot of tortuous blood vessels in the submucosal plexus. The importance of these submucosal plexus of dorsal lingual artery is that when you do a tongue-based surgery, you do get a lot of charring. And this is because of these small minor bleeds. That's why the base of tongues is the lymphoid tissue is supplied very well by the dorsal lingual artery. You can see here the dorsal lingual artery branching out from the lingual artery, supplying the tongue base, and you can see the hypoglossal nerve lateral to it. And another way of identifying the lingual artery is that there is no significant neurovascular bundle in the medial part of the tongue, or the medial septum, or the middle part of the genioglossus muscle. The lingual artery and the dorsal lingual branches lie between the genioglossus muscle and the hyoglossus muscle. So it's medial to hyoglossus, medial to hyoglossus and lateral to genioglossus. And here you can see the relation of the lingual nerve and the hypoglossal nerve as they traverse through this region. There's another picture showing the lingual nerve. And lingual nerve, it provides a general sensation to the tongue, such as pain, temperature, and touch. And also sometimes it also carries some taste fibers. And the nerve basically courses anteriorly and inferiorly between the lingual surface of the mandible and the medial and the lateral surface of the medial pterygoid. Okay, and on the anterior aspect of the medial pterygoid, the lingual nerve runs lateral to the superior constrictor muscle. So in this picture, the superior constrictor muscle is taken away. So if your dissection extends a little bit lower down in the transoral robotic view or towards the neck, you would sometimes injure the lingual nerve, or you might cause compression of the lingual nerve. So patient can have some dysgeusia or altered sensation of taste post-operatively. This is another picture of the lingual nerve, and you see the close relation to the styloglossus muscle. And you can also see the ascending pharyngeal artery, which I told you is a sentinel landmark to the internal carotid artery. Here is another picture, a three-dimensional picture showing the relationship of the lingual nerve and the hypoglossal nerve to the tongue base. So you should be very aware of it during the dissection. So to summarize, the robotic surgeon, especially transoral robotic surgeon, should have a very good knowledge of the inside-out anatomy of the oropharynx and the parapharyngeal space. The styloglossus and the stylopharyngeal muscle represent important anatomical landmarks in TOR's lateral oropharyngectomy. There are aberrations of the vasculature, and you should know very well when you're working up the patient to check for aberrations of ascending pharyngeal, external carotid, and internal carotid artery. And also, you should have know the importance of dorsal lingual artery and its relationship in the tongue base during tongue base resection. So thank you very much, and I'm open for questions, or we go for the next topic.
Probably we can take the questions at the end of the session, sir.
Sure.
So, Dr. Akshay would be talking on the next part of the talk.
Yeah. Anand, can you see my screen?
Yeah.
Thanks, Anand. Thanks, Vidya. It was a wonderful explanation of the transoral anatomy of the oropharynx. Going forward, I'll just try to explain the anatomy of the laryngopharynx from the perspective of the transoral robotic surgeon. So we, right from the medical school, have learned the anatomy from outside in. So we are well versed of the vascular anatomy, the laryngeal framework anatomy, how the ligaments are connecting these cartilages, and the strap muscles attached to it. Based on this understanding and the beautiful descriptions of the laryngectomy and the anatomy understanding, we can easily perform the open surgeries of the larynx, such as the laryngectomy. But the laryngectomy is a very simple operation. There is no need of preservation of any important structures. As a result, majority of them do it very comfortably. But this procedure has a significant morbidity in terms of having a permanent stoma, which has a significant psychosocial impact. As a result, we are moving away from laryngectomy in a significant number of laryngeal cancers, except for the T4 laryngeal cancer when the tumor comes out of the laryngeal framework or if there is a dysfunctional larynx. With the intention to conserve the larynx, numerous open surgical techniques such as conservative laryngeal surgery, that is the supraglottic or supracricoid laryngectomy, have been practiced. And it involves removal of the tumor with margins with the preservation of the laryngeal framework, whichever is oncologically feasible. The main thing is to preserve the innervation in the form of recurrent laryngeal nerve and the superior laryngeal, both the external and internal branch wherever feasible. Even though the results show that the oncological control is excellent, the functional results are not very much acceptable. As a result, and with advances in technology, those cases which were addressed with open conservative laryngeal surgery, now we have moved with transoral laser surgery, and it has been practiced over the last 3 decades. And this has been proven to be equally efficacious to radiotherapy in select subset of glottis, mainly in T1, T2 tumors. But the drawback of transoral laser surgery is that the exposure. So transoral laser surgery is a line of sight surgery. As a result, we may not be able to carry out extensive surgery of the supraglottis. Another drawback of the carbon dioxide laser is that it can only seal the vessels and maintain coagulations of vessels less than 0.5 millimeter in diameter. With the help of robotic technology, the drawbacks of the transoral laser surgery in terms of exposure and ability of the to maintain hemostasis can be easily overcome. So transoral robotic surgery, with the help of better magnification, angle telescopes, better instrumentation, as already discussed by the previous speakers, can easily access and perform procedure on these previously inaccessible sites. So TORS got FDA approval for surgical management of oropharyngeal cancer in 2009, and it has been successful in both in oncological and functional outcomes. Based on the experience gained by the oropharyngeal surgical management, now the indications have been extended for the management of supraglottic lesions, hypopharyngeal lesions, certain selected narrow field laryngectomies, and isolated, especially salvage retropharyngeal node dissection. So before embarking on this surgery of the supraglottis, it's very important for us to relearn the anatomy. So we are always through our training learned the anatomy from the skin to the mucosa, but while performing transoral robotic surgery, we have to understand the anatomy the reverse way. That is, from the mucosa to the skin, what layers we encounter from inside out, and what are the vasculature which we have to deal with to perform a very clear, safe, and very bloodless surgery. So first, coming to the structure, just like from outside, the thyroid cartilage, hyoid, and the cricoid cartilages are suspended with membranes. The inner side, that is on the luminal side, the epiglottis, the corniculate, cuneiform, and the arytenoid cartilages are draped by membranes. The quadrangular membrane, which extends from the epiglottis to the thyroid angle and the arytenoid cartilages, and the free edge of this quadrangular membrane forms the false vocal cord. Similarly, there is another membrane which runs from the cricoid cartilage upwards to the arytenoid cartilage and the thyroid cartilage, and the free edge of this forms the true vocal cord. This membrane is lined in all sides by a ciliated pseudostratified columnar epithelium, except for the true vocal cord, where it is lined by the non-stratified squamous epithelium. We also have to have some understanding about the pre-epiglottic space as well as the paraglottic space while performing these supraglottic surgeries. So any surgery, any new surgery, we go back to the cadaveric labs and perform these procedures and to understand the anatomy. So this is a beautiful description done, given by Goel et al. So who looked into the cadaveric specimen, used Davinci robot to dissect the supraglottic region. So what they found was that when they dissected the supraglottis, once they incised the mucosa, the first structure, muscular structure, which you encounter when you're doing a transoral approach for the supraglottis at the level of the vallecula is the superior constrictor, the middle constrictor muscle. So the middle constrictor muscle gets attached to the hyoid bone, and just lateral to this, the vascular pedicle which comes is the lingual artery. And after the lingual artery, the next muscular layer is the hyoglossus muscle, and beyond that, you find the lingual nerve. So this is the anatomy from inside out at the level of the vallecula. You have, once you cut open the mucosa, the first layer you get is the middle constrictor. Beyond that is the lingual artery, then the hyoglossus muscle, and then the lingual nerve. So once we remove the middle constrictor muscle, then we have access to the thyrohyoid membrane, and that's where you will see the superior thyroid artery deep down, and at the level of the just below the hyoid bone, you can see the superior laryngeal pedicle. The muscular muscle which comes into view after the removal of the middle constrictor is the anterior and the posterior belly of the digastric. When you dissect the medial side of the hyoid bone, you encounter the superior laryngeal pedicle with the nerve which enters the larynx. So some understanding of this nerve is important. Obviously, we will not be able to preserve the superior laryngeal pedicle at the side of the disease. The internal branch of the superior laryngeal nerve, once it enters the larynx, it divides into the superior, middle, and the inferior branch. The superior branch supplies the epiglottis and the infrahyoid epiglottis. The middle supplies the true vocal cord as well as the ventricular region, and the inferior branch supplies the arytenoids. So care has to be taken in the non-disease size to preserve the superior laryngeal pedicle as much as possible to help in better functional recovery of the patients. Next, coming to the superior laryngeal vessels. So superior laryngeal vessel enters the larynx or the supraglottic region through the thyrohyoid membrane, and once it enters there, it branches and it courses along the supraglottis. So it's important to understand the landmarks at which these branching happens. So again, this is a beautiful cadaveric study done by Piazza et al. From Milan, Italy, where they did a cadaveric dissection on about 11 fresh frozen larynx, fresh cadavers. They injected the silicone red gel into the artery, and the idea of their study was to find to understand the course of the superior laryngeal artery once it enters to the larynx, and look at the branching patterns, and also look at the diameter of these vessels at specific anatomical landmarks. The superior laryngeal artery, once it enters the larynx, it gives a epiglottic branch that supplies the epiglottis, and beyond about 6 millimeter beyond that, it gives the anterior and the posterior inferior artery, which for the posterior inferior artery further divides into the anterior and the posterior branch, and these communicates with each other, as well as the paracommissural artery, which is a branch of the cricothyroid artery, which is a branch of the inferior laryngeal artery. So what is interesting to note that majority of this branching has a median diameter of 1.4 to 1.6 millimeter. That is why these procedures are difficult to be carried out with transoral laser microsurgery, and this understanding of this anatomy helps us in performing robotic surgery as well. So when you look at the endoscopic view, you can see that the superior laryngeal artery enters into the intraluminal region, and the first branch, the epiglottic artery, runs through the pharyngoepiglottic fold. And once about slightly beyond that, the superior laryngeal artery further branches into the anterior inferior artery, which supplies the ventricle as well as the vocal cord region. And the posterior commissure artery further divides into the posterior branch and the anterior branch. Obviously, when there is a tumor sitting on this region, we cannot individually ligate these branches. We go to the main pedicle at the entry point of the thyrohyoid membrane and ligate it. But on the non-disease sides, we can individually clip this and carry out the procedure. Another artery which comes in the region of the vallecula, just lateral to the middle constrictor, is the lingual artery. So when you're performing the supraglottic laryngectomy, you may encounter the dorsal lingual branches of the lingual artery, which needs to be clipped or cauterized to carry out a bloodless procedure. Moving on to the hypopharynx, in terms of vascular anatomy, it's quite similar. But as Vidya beautifully pointed out, the constrictor muscle, so just beyond the constrictor muscle, just like the superior constrictor, middle constrictor in the oropharynx and the hypopharynx, the inferior constrictor will be there beyond the mucosa at the level of the hypopharynx. So if you have an extensive surgery, if you have a lesion in the piriform fossa apex or the lateral pharyngeal wall, which requires excision of the inferior constrictors for margin, then there is a chance that you may communicate with the neck. So you need to have a plan for reconstruction in that situations. And also, we need to be cognizant that there are great vessels which are there in the beyond the constrictor. So this has to be bear in mind. Just a word about retropharyngeal node dissection. So retropharyngeal node dissection, as we know, the retropharyngeal space is nothing but a space which is behind the buccopharyngeal fascia and the alar fascia. And this retropharyngeal dissection is really a morbid surgery when you're doing it in an open fashion, in a traditional way, because it involves significant dissection of the digastric, need to cut the digastric, the stylohyoid muscle, significant traction of the glossopharyngeal hypoglossal nerve to reach the retropharyngeal space with the ligation of the external carotid artery branches with a medial approach. This retropharyngeal dissection can be done in select cases where for example, nasopharyngeal carcinoma treated with chemoradiation in a follow-up PET CT scan shows a isolated metastasis in the retropharyngeal space. So these situations can be dealt with the transoral approach using robot. As Vidya mentioned, the internal carotid artery is a very important structure to look for the preoperative evaluation in the radiology. You look for the axial CT scan, and because the incidence is as high as about 10 to 15%. So this was considered as a relative contraindications for transoral robotic surgery, and all procedures before we embark on robotic surgery, we need to look at the axial scan specifically to look at the relation of the internal carotid artery. and the classification with Vidya mentioned. So this grade 2 and grade 3, when the internal carotid is less than 5 millimeter to the pharyngeal wall, this was considered as a relative contraindication for transoral robotic surgery. However, this beautiful description by Weinstein et al. And group, they performed the situations where patient had an aberrant retropharyngeal internal carotid artery, where the superior part of the dissection was done with the robot with a transoral approach. And anyway, these patients required neck dissection. And when they did a neck dissection, they dissected the internal carotid artery right up to the level of the oropharynx, and then performed the oncological surgery of the lower part through the neck with control of the internal carotid artery. And these were, of course, reconstructed with the skin-lined flap to both to close the oral cavity defect with the neck, as well as to cover the carotid vessels. So this is in the brief about the anatomy of the laryngopharynx.
Thank you both of you for a wonderful presentation to orient us to this new anatomy, which is turned inside out, whereas usually people are used to from the external to the internal approach, and this is something which is new. So there was one question that had come in earlier, who had asked that does the same hold good for any transoral procedure?
The anatomy wise?
Yeah, anatomy wise.
Yeah, so anatomy it remains the same. So see what that article by Piazza group on the endolaryngeal branching pattern. So it's a beautiful anatomical description of the vessels. So anatomy doesn't change irrespective of the approach, whether using a robot, you are using an endoscope, using an harmonic scalpel. It doesn't change. The anatomy remains the same.
Another question was, say, considering the margins. So the general consensus has been 1 centimeter of mucosal margins 3-dimensionally and 0.5 centimeters of pathological margins is what considered ideal for oral cavity, and kind of similar in the other subsites as well. But a lot of times you will not be able to achieve the lateral anatomy, the lateral depth, say when the tumor is more infiltrative. Any thoughts on that? Like any suggestions or any take on this?
So when can I answer this?
We
also have two transoral robotic surgical experts in the few of the transoral robotic surgical experts in the participants, Professor Palleri and Suren Krishnan and Professor Sang. Maybe they can also add in their points. But with regarding to the lateral or the deep margin, you need to see it in your preoperative workup. Usually, if it's beyond the superior constrictor, the knowledge initially when you're a trainee surgeon, they say try not to do a transoral robotic surgery. But for higher stages or the tumor going beyond the superior constrictor, there are ways you can, because you need to study your scans properly, and you need to know what structures you can take out. That the same goes to the lateral part of the larynx also, because it's bounded by the thyroid cartilage. Actually, you can comment or you can add.
I think Professor Palleri or Professor Krishnan can make a point on that, I think.
Suren Krishnan here. I don't know if you can hear me.
Yes, sir. We can hear you.
Thank you. Thank you again, Akshay and Vidya, for inviting me. With regards to this particular point, it's one that I'm very passionate about. And that is that this has to be understood to be a compartmental resection. So the depth of your resection has to be the anatomical structures that your tumor sits on, and you need to have very good radiological assessment of the depths of your tumor. So in our multidisciplinary clinic meeting, the radiologist will tell us the relationship of the tumor to vessels, relationship particularly to the styloglossus and the constrictor. And based on this, we would proceed on whether this is a tumor that can be resected transorally and robotically. But the depth of invasion is finally determined, of course, by the final pathological result. But if you study the radiology, you can take the styloglossus in its entirety, protecting the carotid vasculature, and get yourself a good clearance in depth as well as in terms of mucosal margins.
Right, Professor Palleri, your comments?
So we have to look at this from a different angle as well. If you hark on the 5mm margin on a consistent basis, the issue is that the 5mm data set was derived from a single paper published in the 1970s with 65 patients in it. But if you look at the rest of the literature published since then, there's a large 190 paper data set from Glasgow, a 300 plus data set from Iowa, and a 290 data set from MSKCC. So you put them all together for oral tongue lesions, the predominant margin that works out to be the ideal margin that predicts local recurrence or not is between 1.1 to 2 millimeters. Again, if you look at the transoral laser microsurgical data or the transoral robotic surgical data, where you have had single modality alone to decide if your patients get local recurrence or not, again, robust analysis puts the margin between 1 and 2 millimeters, which is why we think in the vast majority of instances where single modality suffices, 1 millimeter or 2 millimeters is sufficient. We have to move away from the 5mm that's been drummed into us over the years. We have to move away because not a single data set supports the 5mm cutoff. Every other bit emerging. We've just published our 51 cases, toes alone, and we have a local recurrence rate that is similar to the ECOG 3311 arm A, which is 92% local control, median follow-up 30 months. And our data indicates that the optimal cutoff is 1.1 millimeters. So very little evidence at this point in time, to my knowledge, continues to support the 5mm cutoff.
Any thoughts by Dabas sir on this?
Hi Akshay and Vidya. So till now we have done around more than 800 robotic surgery in head neck, and I will tell my experience for 3 sites. So one is tonsil cancer, one is base tongue cancer, one is the tonsil cancer going to the soft palate. So one of the most dangerous part is the tonsillar cancer going to the soft palate. So the deep margin, yes, like Dr. Pereri and Dr. Sanin had certified that the deep margins 2 mm is very difficult to achieve. And once you're doing a surgery, there's a plane, avascular plane between the superior constrictor and the medial pterygoid, and you always see there is no tumor infiltration, so your maximum margin can be 1 mm. So even if you take out the medial pterygoid fibers, it is not going to achieve good surgical margins. But if you see the local recurrence in our series is not more than 4%. And then if the tonsil cancer go to the soft palate, yes, I always say take out the soft palate in toto. Don't try to save the soft palatal structures when you are taking out the soft palate, because this is one of the most dangerous point for recurrence. Now base tongue. Assessment of the deep margin base tongue is very, very difficult. So when you're doing surgery, you can see the tumor is popping out. When you're doing a surgery, you will go a bit away from that. But again, you can achieve a margin of maybe around 1 or 2 mm more. So achieving a deep margin of 5 mm is not possible in TORS surgeries. And when you go in retrospect, even for HPV negative or maybe HPV positive, the deep margin is again the structures are same. 2 mm deep margin achieved is a good margin, basically the deep margin. And then we see our data, the local recurrence, again I'm saying in all the series, you leave apart the small soft palate is less than 4-5%. It's not more than that. So I think speculating around 5 mm margin and saying the deep margin is very close, you have to make a good understanding with your radiation oncologist. Deep margins, whatever, you are a great surgeon, you cannot achieve 2 or 3 mm. It's very difficult to achieve. So we should keep in mind deep margins should be assessed by the surgeon, not by the radiation oncologist. Okay.
Thank you all. So probably we'll move on to the next talk. That's a talk by Professor Surain Krishnan from Australia, who will be talking on TORS for parapharyngeal space tumors, tips and tricks.
Now, let's see if I can get this to work. Now, do you have my screen on view?
Yeah.
Anand? Good.
Yeah.
So, thank you again, Vidya, for inviting me to give this talk. And I'm talking about a very small application for transoral robotic surgery, and that is the use of transoral robotic surgery for parapharyngeal space tumors. Greetings from Adelaide. Let me just see if I can make this move. Firstly, just to disclose that I do some proctoring for Device Technologies, who is the wholesaler retailer for the intuitive Davinci robot system, and also do some proctoring for COMeD Robotics, who have the Flex robotic system. But I will tell you that all those funds go to a foundation I work with that does work in lower middle income countries in the Asia Pacific and Africa. This is a short greetings from Adelaide, and hopefully Vidya and Vin Paleri, who was our fellow in Adelaide, will see some of these with fondness. Here are some beautiful vineyards in South Australia, nice furry animals from Adelaide, lovely beaches, although the temperature today is about 5 degrees in Adelaide, not good beach going weather. And take time to acknowledge my mentors at the Royal Adelaide Hospital and my colleagues at the Royal Adelaide Hospital. Everyone knows a very famous professor who's an expert in skull base and endoscopic sinus surgery, but we've got a wonderful talent with microvascular surgeons in our team, Andrew Foreman, Rowan Valentine, and Sam Bose joining us in the last 3 or 4 years. This is the old Royal Adelaide that Vin Paleri and Vidya worked in. And sorry, this is our head neck multidisciplinary clinic, who I think were significantly involved in our move to transoral robotic surgery. But this is the new Royal Adelaide Hospital. It's a $2.7 billion investment by our government. And this is our Health and Medical Research Institute, which is again about a $1.5 billion investment by our government. And in the next 5 years, we'll have a proton center, again, another $1 billion investment by government. So there's a lot of investment in health in the health sector. So the Royal Adelaide Hospital, just to introduce you all, it was the first center to perform transoral robotic surgery in Australia. We did this in July 2008, and now we have an experience of over 400 Davinci cases and about 100 COMeD robotic flex cases. And we've got experience with transoral oropharynx, tongue-based cancers, laryngeal tumors, neck dissections, submandibular gland dissections, and surgery for sleep disordered breathing. And we've contributed to the literature, both by publication, book chapters, presentations, and we've also contributed to the training of transoral robotic surgeons, both locally and internationally. I took time to put a photo of Vin Paleri here because I think it's fair to say that when Vin was our fellow, I think it was 2004, we taught him transoral laser microsurgery, and I think he translated that to transoral robotic surgery, and now, of course, is a highly eminent transoral robotic surgeon, and it's wonderful to see his progress. So my plans are to talk about the surgical anatomy of the parapharyngeal space, much of which has already been discussed, talk about some of the clinical issues about the parapharyngeal space tumor that lends itself to transoral robotic surgery, and then give you a small experience of 10 cases. And I'm sure that in India, you will have multiples of that by now of that experience, and tell you some tips from my experience with TORS for parapharyngeal space tumors. And here are my references, and I point to this article by Farouk Rifat, who is based in Westmead at Sydney, New South Wales, and he and his colleagues looked at 1,100 parapharyngeal space tumors, and this is a very good article for any younger doctors looking for a comprehensive review of parapharyngeal space tumors. In our speakers is Raymond Sang, and Raymond and his group wrote up, again, a very good, very contemporary paper on parapharyngeal space tumors. But I still think that the best reading for parapharyngeal space tumors is Kerry Olson's paper from nearly 25 years ago, published in Laryngoscope as a supplement. And I think that that has been the basis of the understanding of many of our views of parapharyngeal space tumors and the surgical approach to the parapharyngeal space. But essentially, again, it's been talked about before, but I think it's a simple concept to consider this as an inverted pyramid with rigid boundaries. It's got a rigid skull base, which is its base, a rigid posterior wall due to the condensation of fascia from tensor veli palatini to the styloid, sometimes called the ligament of Zuckerkantel and testude, which forms a very rigid base, and then a bodilateral wall, which is the mandible, and of course the very prominent fibers of the medial pterygoid. And the styloid process then divides this into a pre-styloid and a pro-styloid component. And as we've heard from Vidya, and the pre-styloid component contains some parotid tissue, some fat, lymph nodes, and ectopic salivary glands. And the post-styloid component, of course, contains the internal carotid artery, the internal jugular vein, the lower cranial nerves, and some lymph nodes. I think this picture again demonstrating a left mandible and the left pterygomandibular, stylomandibular ligament shows how a tumor in the parotid can escape through this stylomandibular tunnel into the deep parapharyngeal space. And here's a clinical example of that with retracting the mandible and a retractor against the sternomastoid muscle. And I hope you can see here the condensation of fibers that forms the stylomandibular ligament and the stylomandibular tunnel. And here's this digastric muscle, which is a key indicator when you approach this region from a transcervical approach to identify the parapharyngeal space. This is an example I'd like to show. This is from a patient I saw in my trip to Indonesia. Over the last 25 years, I've been doing work in lower middle income countries in the Asia Pacific, and see some interesting pathology, which you who are in India will see on a more regular basis. But here's a tumor that caused this patient some airway symptoms to the point that the anesthetist that was with us felt that we needed to do a tracheostomy before we could attack this lump surgically. And you can see here this lesion in the palate, moving the tonsil to the midline and across. And here you can see my fingers across the band of the stylomandibular ligament. And once this ligament is broken, you can see this tumor explode into the neck, and this lesion that extended from the deep lobe of the parotid through the stylomandibular ligament, the deep lobe, and then into pushing the submandibular gland, was removed and was found to be monomorphic adenoma. So just very quickly, these tumors are 50% in the pre-styloid region, mostly salivary gland tumors, mostly benign, but there are some malignant tumors. And it's very important that if we're dealing with malignant tumors, that we identified it early, and fine needle aspiration is a very important part of our workup of these lesions. But a significant number of these lesions are neurogenic tumors. And it's important again to assess these because of the risk of injuring adjacent structures, particularly the lower cranial nerves. And so we must have very clear indications of why performing surgery. Lesions can also be benign, and there's some branchial cleft cysts that occur in this region, and I'll show you a quick video of one of these lesions. But they can also be metastatic from adjacent sites by direct spread or by hematogenous and lymphatic spread to this area. Usually these lesions are found incidentally. Patients have a sore throat, are seen by the general practitioner, and an incidental oropharyngeal mass is found, or found incidentally on investigations for other reasons, MRIs, CTs, or CT-PET scans for other lesions, and then these are found. More sinister, of course, is if these lesions are associated with neurological deficits of the lower cranial nerves, Horner syndrome, trismus, or if they have symptoms associated with systemic expressions of disease, like catecholamine excess in paragangliomas. Again, always good to take a good history and examination, and of course, key to this is the facial nerve and the lower cranial nerves. And of course, very key to deciding what kind of surgical treatment you're going to take is to have good radiology. And we would routinely do CT and MRI scans. We would try and get a fine needle biopsy of these, either transorally or by CT guidance. And if you suspect a paraganglioma, then 24-hour urinary VMAs to see if these lesions are expressing catecholamines. The radiological evaluation, again, quite obviously important to understand the relationship to the parotid gland, because if this is related to the parotid gland, then you need to treat the parotid as well as the tumor in the parapharyngeal space. The relationship to the great vessels, that is both how the vessels are displaced by these tumors, or whether the vessels are encompassed by these tumors, and CT scans to assess any bony involvement. And again, the parapharyngeal fat plane is a good indicator of whether this is a tumor of the salivary gland, especially its deeper aspect going through the stylomandibular gland into the parapharyngeal space, or whether this is truly an independent parapharyngeal space, salivary gland tumor, independent of the deep lobe of the parotid gland. Sometimes MR and CT can give you the diagnosis. Flow voids will tell you that this is possibly a paraganglioma. And of course, if you have a completely black lesion on a CT scan, then that might tell you that this is in fact a lipoma. For tumors that involve the carotids, balloon occlusion and embolization as part of angiography may be considered. And if for metastatic lesions, then PET scan can help identify metastatic disease. As I said, the key thing of all of this is the facial nerve. And as we all know, the facial nerve is where you find it, and its normal anatomical position can be displaced by the tumors in the parapharyngeal space. These tumors almost always require a surgical excision, but it's very important to try and make sure that it is a tumor that does require surgical excision. So every effort must be made to try and ascertain whether this is, for example, a benign lesion that is slowly growing, such as a schwannoma or a paraganglioma, and to make sure that surgery does not put at risk multiple lower cranial nerve injuries that make your patient a swallowing cripple or a breathing cripple. Also important to understand if tumors involve extensive skull base involvement or intracranial extension that make it unresectable, as it is also considered alternatives such as observation on a regular basis by MRI, or consider radiation therapy for appropriate lesions. So going back to the surgical approaches, as I said, Terry Olson's paper, I think, puts this very clearly. And he, in his paper, at his time, 25 years ago, mentions the per-oral approach as an approach to mention, but to discount. And we'll elaborate on why that is later on. But the standard approaches are a transcervical approach, which is very successful in getting truly independent lesions in the pre-styloid space. Sometimes for large lesions, you may want to consider an angle mandibulotomy. But as I said, most benign lesions in this region can be removed transcervically. For large lesions, again, and particularly lesions involving the deep lobe of parotid, you might want to consider a cervical transparotid approach, and again, the option of mandibulotomy. And for large, particularly vascular lesions such as paragangliomas, glomus tympanicums, that you might need to do a transparotid and transmastoid approach. And then there are a variety of approaches for lesions that extend into the infratemporal fossa that involve both a transcervical, transpharyngeal, combined with infratemporal and transcranial approaches. But here we are trying to discuss a simple approach to the simple parapharyngeal space lesion that lies truly independently in the pre-styloid space and not connected to the deeper lobe of the parotid. And this is not a common lesion as shown in my very first slide. If you look at even the big series, such as from Mayo and elsewhere, they report about 3 or 4 cases a year. And even if you look at Farouk Rifat series of over 1,100 cases, the incidence throughout the world was something like 50 cases a year. So these are not common tumors. The reason why the original transoral approaches were criticized was because of the poor view and the poor access to instruments, and therefore the resultant risk of injuring the neurovascular structures in the parapharyngeal space and the risk of tumor spillage, which was always considered a very bad outcome. But if people are honest, those who've done this operation transcervically, particularly for large lesions, the top end of your dissection does not allow for visual access, and almost always is a blind, blunt finger dissection. And by the grace of God, these lesions often have quite a thick capsule. And if they have a thick capsule, then one can virtually enucleate these lesions and deliver them through the transcervical wound. But if you are unfortunate, as I've been on some occasion, when the capsule of this tumor is thin, or if the tumor is very cystic, then there is a risk that this lesion will become disrupted. The cyst wall will be disrupted and tumor will be spilt in the wound. And my plan with these often in the old days was to then put a telescope into the transcervical wound and try and identify any spilt tube and remove it and irrigate copiously with water. So the surgical approach nowadays is, again, for the truly independent lesion in the pre-styloid parapharyngeal space, is a transoral robotic approach or a video-assisted endoscopic approach as practiced by the Japanese. But this really does depend on good assessment of the tumor, trying to recognize the size of the tumor, its location, relationships of the great vessels, and to exclude malignancies. And to this end, it's very important to have good radiological information and assessment. And as I've said before, understanding the relationship of the nerve to the carotid artery and whether it's displacing the carotid artery medially, understanding its relationship to the facial nerve, whether the lesion is large, whether its capsule is thin, and whether this is in fact truly within the pre-styloid place or space, or whether it's a dumbbell tumor related to the deep lobe of the parotid. So here's an MRI that shows a lesion which is thin-walled, which is cystic. It does have a parapharyngeal space, a parapharyngeal fat space preserved. So this is truly independent of the parotid gland. Here, the internal carotid artery is not displaced medially. It still potentially can be traumatized, but being aware of its position allows you to plan your surgery carefully. And it's important to recognize that these tumors are accessible robotically because of the robot's very good visual access. We've already had talks about the magnified view you can get, the filtration of tremor, and the access by 8mm instruments, and the use of adjuncts to prevent spillage. So, what we tend to do is to infiltrate transorally and create a plane of hydrodissection using about 15 or 20 mils of 1 in 100,000 adrenaline saline, and then use controlled decompression using neurosurgical patties in our dissection to ensure that we do not cause any trauma to the thin cystic wall of these tumors. Professor from Korea, whose name has just escaped me, Kim Se-on, describes a technique, I think he calls it morselization, using an endoscopic debrider to decompress the tumor and allow you to limit the rupture of the tumor, and with good visualization and debridement removal of the tumor. Once the tumor is removed, if there is spillage, what the robot allows you is good visualization by magnification to allow you to irrigate the bed and remove any debris in the bed. So our technique is an endotracheal intubation by an oral tube, as we would use for tonsillectomy. We like to use these transparent cheek retractors to give us wide access to the oral cavity. We just use the standard Boyle-Davis gag. We use a 0, but very useful is a 30-degree telescope turned upside down to give you a clear view of the superior aspect of the tumor. We use the Steiner Transom Laser Kit, which has a insulated diathermy tip, a clip applicator, and some gentler graspers to be used by the assistant. And you do need to have a trained assistant who understands the complexities of the tumor, as well as the risk of traumatizing the wall of the tumor. And we tend to use fenestrated bipolar forceps. These are a bit more gentle to the wall of the tumor, both in terms of grasping and also applying pressure and deflecting the tumor as you dissect the tumor. So this is our standard approach. And I'll just show you the steps. The steps are to make an incision, to elevate the flap, and then having elevated the flap, then to make incisions superiorly, medially, laterally, and inferiorly, and then finally posteriorly, and then deliver the tumor. So this is a 3-minute video that shows resection of a right-sided parapharyngeal space tumor measuring about 6 by 5 centimeters. And this patient's tumor is, so we use both a 0 and a 30-degree scope to resect these tumors. And so this is the tongue. This is the suction held by the assistant at the bedside. This is the robotic instruments manipulated by the surgeon at the console. We make an incision on the pterygomandibular raphe, and you can see that this patient, you can see how there's some turgidity here because we've hydrodissected. We put an injection. I think that might have been where we put our injection of saline, about 10 or 15, sometimes 20 mils. And this creates a plane between the tumor capsule and the mucosa, and you can see some fibers of possibly constrictor. And here you can see us dissecting the tumor away from the musculomucosal flap, for want of a better description. And again, this is generally done without too much difficulty in cysts that have, in tumors that have a thick cystic wall. But sometimes if you are unfortunate and there's a very thin wall, you can breach the cyst wall somewhere during this dissection. You'll see that the dissection is both a blunt dissection technique as well as using the diathermy very sparingly so that you don't again have heat damage to the wall. And here you can see now us dissecting the tumor away from the superior and then the lateral margins, working our way inferiorly. And this tumor on the CTs we identified was abutting the submandibular gland. And so we are working our way now inferiorly. You can see here the lower mandible, and here we are going into the floor of mouth, and the submandibular gland will become visible soon as we dissect the tumor out. And your assistant is very important. You don't want the assistant pushing too hard and being too aggressive with the sucker, because again, that's another opportunity to perforate the cyst wall. And finally, we are now dissecting the tumor of the posterior wall. And I might just move the video along. So this is the final bit of dissection of the posterior wall. And this is a sucker that we put in to just suck out the, and cause some circulation of air to stop the telescope from demisting. And here you are, the final bits as the tumor is being removed. Always good to see the tumor come out. And here's the tumor coming out. So there we are. So our experience, as I said, is 10 cases, almost all of them pleomorphic adenomas. One was a schwannoma, which I will show you, was a tumor that had been monitored for about 6 months and that was felt to have increased in size substantially. And this is a video of a case that Vidya for us when he was our fellow. This was a type 4 second branchial arch cyst, and here you can see the tumor, the mucosa being incised. There's the cyst, and here's the carotid vessels, and they are being carefully dissected. And then we decided to decompress the tumor because of its being stuck to the vessels. So here's a decompressed branchial cyst, and here's the cyst coming out. So here's an example of a benign tumor being resected in from the parapharyngeal space. This is that schwannoma case that I was telling you about that showed a sudden increase in size. It probably had a hemorrhage within it, but again, we took this out transorally, robotically. And here's an interesting case where we used a combined approach in a 15-year-old boy. We decided that we felt that this was truly in the parapharyngeal space, but was a bit uncertain about what its relationship with the parotid gland was. So we made a small preauricular incision, identified the facial nerve, put in a green colored plastic strip to protect the facial nerve, and then took out the tumor transorally robotically. So I think the key concern of everyone when it comes to pleomorphic adenoma is spillage of tumor. If you look at the literature, generally speaking, if you control this by minimizing the amount of spillage, recurrence rates are small. Certainly the recurrence in parapharyngeal space is regarded as small. The trick, I think, is this hydrodissection technique and being gentle, having good assistance, and the concept of decompressing the tumor to ensure that you don't rupture the wall. But if there is rupture, irrigate the cavity and closely inspect the cavity at the end of surgery. So in summary, parapharyngeal space tumors are amenable to transoral robotic resection. Key to a good resection is very careful assessment of the anatomy and input from the radiologist is vital. Understanding the relationships to the vessels, understanding the relationship to the deep lobe of the parotid. It's important to get a needle diagnosis if you can by at least 1 or 2 biopsies so that you can be prepared to consider other approaches. That if you do get spillage, then the important thing is to have a good look at your bed and inspect it and irrigate it. We've fortunately not had, and the literature to date doesn't support that there is much in the way of recurrences. And of course, understanding and approaching the parapharyngeal space with the robot leads to an evolution of application of robotic surgery for the skull base. So thank you again, Vidya and Akshay and the team for inviting me, and I am now open for questions.
Thank you, Professor Krishnan. It was a wonderful presentation, quite a lucid one. There's a question. So given a lot of these lesions in the parapharyngeal space are benign lesions, say for example, a schwannoma, and operating on one of them often leads to neurological issues. So when do you decide not to operate them, and what are your protocols to follow them up?
So our tendency with, if we have a diagnosis of schwannoma and the patient has no symptoms, is to observe them. So we would only consider operating on them if they developed a sign or symptom of concern. So this particular patient was followed, I think, for about 2 years, and there was a sudden change in the size and the appearance of the lesion. And as a result, we chose to operate on them. But our general principles with a diagnosis of schwannoma, which can be made by two means, firstly, by the radiological features, and secondly, if you do a fine needle biopsy on these, they're exquisitely painful. So patients will jump when a needle goes into the lesion. So that's often reported by the radiologists. And the pathologists are pretty comfortable now marrying the radiological features with the finding of just spindle cells. They don't seem to have enough tissue to do immunohistochemistry, but sometimes if they do, then if they got the S100s and the enolase, and there's one other marker they use, then they will be happy to call it as a benign schwannoma, and we watch it.
So the second question is, with provided the magnification, 10 times of magnification increase the dexterity, are you able to perform fine dissection of the nerves away from the tumor? Like, what is the nerve preserving rates?
So for schwannoma in particular, as I said, our experience is only one. From my experience with schwannomas, when I've done them through the neck, and I've usually done them because the patients, usually they're women, and usually it's because of the cosmetic issues of a lump in the neck. So the few that I've done, the technique is not one of an excision technique, but more of a debulking technique. And in those, you will get at least preservation of tone. There was one case that I remember, which was a facial nerve schwannoma that we did not identify as a schwannoma preoperatively in a young pharmacist, but the lesion was something like 10 centimeters in size. So it had suddenly increased, and the technique was basically an incision into the capsule of this lesion and basically evisceration of this tumor. If you read the pathology of these, it is said to be occurring, of course, peripherally on the sheath of the tumor and compressing the nerve. And often, in the case of this facial nerve, I remember very clearly when we removed it, we had the impression that the facial nerve, we could see it as it exited the stylomandibular foramen, and that it sort of fanned out as a thin nerve. But yes, no, my recommendation would be not to operate on a schwannoma.
Great. So I have two questions to ask. So one is, when you're performing a TOS for a parapharyngeal space lesion, when do you decide that you need to, what are your boundaries or the limitations to resect a tumor just by TOS or with a combined approach or open approach? Like, what are the determinants that you look at?
So for us, I think now, if there is a clear parapharyngeal fat plane, then we would be very comfortable taking out tumors transorally from the parapharyngeal space. We do have significant concern about the position of the internal carotid artery. We've heard about the anatomical variation, but these tumors tend to displace the artery medially. But again, if you're forewarned and you know about that position, you can almost always do your dissection carefully enough. And again, by staying close to the capsule of the tumor and not wandering away from the capsule of the tumor, you can avoid injuring the vascular structures. The problem is that if you have an inflammatory lesion like a branchial arch cyst, and we've now got 2 of these, the problem is that the inflamed tissue around the cyst does not allow you to identify the vessel wall as easily as in a tumor capsule, which seems to peel off most of the structures. So the danger really is in the parapharyngeal, the recurrently inflamed parapharyngeal branchial cyst. And again, it's not impossible. You must be careful when you use the spatula, not to use it as a diathermy implement all the time, but to use it as a dissector and to be patient, and it's still possible to remove inflamed branchial cleft cysts in this region.
Second question is, after all these resections where considerable amount of mucosa is preserved, do you suture back the mucosa?
So I don't. If you go to Greg Weinstein's course, he recommends suturing it closed. But we have found that the parapharyngeal space is a potential space, and the mucosal incisions collapse down so that once you take the tumor out and you look in the oral cavity, everything closes down. And so our general tendency is to probably put, if anything, maybe a suture at the lower end, so that if the lower end is going to be a sump where saliva collects, then you have some seal. But our tendency is not to put any suture at all.
There's one question from Professor Pelleri. Any experience with paragangliomas through this approach, the transoral approach?
So unlike Vin, I'm a very scared man, and I haven't done paragangliomas transorally robotically. I'm still doing my paragangliomas transcervically. But I think there has been description in the literature of people attempting paragangliomas transorally. I do remember reading it as a one-off case report, but it's not one that I would probably undertake myself.
Thank you, Professor Krishnan, for a wonderful presentation and taking the questions. We'll now move forward to the next talk, which is by Professor Raymond Sang from Hong Kong, who will be talking on robotic surgery of the skull base.
Thank you very much. I'd like to thank Dr. Vinod and Dr. SK for inviting me for this CME activity. Greetings from Hong Kong. We're here very hot at 33 degrees in a Sunday afternoon. I'm going to talk about actually robot. Let me just start sharing my screen. The robotic surgery for the skull base. Initially, I thought I was going to talk about a bit on parapharyngeal space tumor and a bit on my experience on the nasopharynx. But since Professor Sharan Krishnan has already given an excellent talk on the parapharyngeal space tumor, you consider this as actually the part 2 of the skull base, which is basically nasopharynx. Okay, torsion and skull base. I mean, if you look at the literature,
Professor Sang, your presentation is not up yet.
It's not yet. Okay,
yeah.
Let me have a look. Okay, is it okay?
Yeah.
Are you serious?
If you could just put it up as presentation, in the presentation mode.
I am, but somehow they are not allowing me to do that. Let me just try it again. I might have to do it in this mode, unfortunately, because somehow it doesn't allow me to share it on. Let me just share screen again. And okay, is this okay for you? Yeah. Okay. Unfortunately, I don't think I can get it into presentation mode. I'll use this mode. So let me just go on again. I'm going to talk about basically the other part that we use TORS for is to use it for nasopharynx. We use mostly in the skull base either for the parapharyngeal space tumor and also for the nasopharynx. Now, when we look back at the literature, when they first have this skull base, especially the group in the pen, they actually did some experiments trying to use the robot, for example, to suture dura, to do lesions in the odontoid process and some of these really skull-based lesions. But we all know the robot, there isn't any bone instrument. So a lot of the work around the skull-base area, you really need to deal with bone. So most of the work that we do in the anterior skull base now are either in the nasopharynx or the parapharyngeal space, where it's mostly soft tissue work. So the enthusiasm was lost soon after for the TORS for skull base, mainly because first there's not a lot of skull base disease compared to oropharyngeal tumor or laryngeal cancer. And also the robot we're using are actually quite bulky. It's quite difficult to deploy. And more importantly, two of the vital instruments that we need for skull-based work, the navigation and the bone instruments, are absent in the robot. Or it's very difficult for us to use the navigation, although we are now able to use it. I'll talk about that later. So it ends up that the robotic skull-based surgery, today I'm not going to talk about lateral skull-based, but there are some experiments on robot doing automated temporal bone drilling, for example, even for doing cochlear implants. But today I think the audience are mostly, we're talking about endoscopic anterior skull-based, where simply you can use the robot as a scope holder. There are actually some of these simple, well, you call it a robot, but more like a robotic scope holder or TORS. And also we are now seen robots on the other side of our other specialty, orthopedics, are using robots for joints and also for spine surgery, mostly for putting pedicle screws on the posterior spine, but this is beyond what we're talking about today. So basically, ends up in two tumors in the skull base, two applications, the nasopharynx and the parapharyngeal space tumor. Sharon already given an excellent talk on the parapharyngeal space, so I'm going to just concentrate a bit more on the nasopharynx and sharing my experience. So why do you want to use a robot? Well, one of the major benefits of a robot, which a lot of people don't recognize, is actually a very stable endoscopic viewing platform, a very stable scope holder, totally under control of the surgeon. If you have ever worked with an inexperienced person holding a scope for you when you do operate, you you want to curse. You're going to end up with a lot of vulgar language speaking when they can't really hold the scope and give you all the dizziness. The other thing is when we work on our endoscopic instruments, especially when we do our endoscopic skull base in the nasal, we lost the wrist. So we lost a lot of degree of motion. And a lot of the dissection we use in open surgery are impossible, like the traction, contraction, suturing are very difficult when you use a conventional nasal endoscopic instrument. Whereas the robot will give you back that wrist, which we mentioned before, and allows you to do some of the complex manipulations like suturing. So, but there are a lot of challenges when you deploy the robot. One of the things is how do you deploy it, whether it's transoral or transnasal, and how do you integrate with the navigation, and how do you deal with the bony structures. I'm going to talk a bit more on the robotic deployment first. Transnasal deployment. I mean, this seems to be very obvious because people are doing endoscopic skull base, endoscopic nasopharyngectomies. Everything is going through the nose. And we're more comfortable, especially rhinologists are more comfortable with anatomy going through the nose and viewing on the nasopharynx from the end-on view. But the problem is the robots are really quite bulky, and you need to remove a lot of bony structures to gain space for movement. That will include the posterior septum and the medial maxillary wall. And also the lateral extension is going to be hampered by the lateral pterygoid plates. So you're really basically only able to talk on the central located lesions. But the good thing about a transnasal deployment is there's no injury to the swallowing mechanism, namely the muscles of mastication and the soft palate. So this is actually an experiment done by the Korean group in Yonsei, where they actually successfully did cadaveric nasopharyngectomies, deploying this robot through the transnasal and transantral route. So basically, the scope is going through the nostrils, and the ports are going through two canine fossa antrostomies. And the variation is you can actually switch the ports behind, and you can get, and after doing a posterior septectomy and bilateral medial maxillectomies, you get a very excellent view of the central nasopharynx. You can see you actually have enough room to doing good dissections around this area. For example, if you have if you have a nasopharyngeal cancer or you have an angiofibroma, you can actually dissect all these dissections. But the disadvantage is this structure here is underneath the mucosa, is the medial pterygoid plate. You're very difficult for you to go beyond lateral to this because this bone is going to be in your way. And if you have to go lateral to it, you have to take down this bone, which is another very tedious process of drilling down the whole pterygoid plates, and with a lot of bleeding when you try to dissect the tissue around of this, the muscles around the medial pterygoid muscles around this area. It's still possible, and I know that Dr. Heng An Tay from Singapore has done nasopharyngectomies with this approach. So the other approach is a transoral approach, which is similar to what Suren has just done on the parapharyngeal space. There's a lot of room for instrument deployment, and after you incise the pharyngeal constrictors, it's very easy to access the parapharyngeal space. The only thing is the soft palate may obstruct some of the access to the superior part, to the nasopharynx and the sphenoid area. So how are you going to tackle the soft palate? So you either split the soft palate and expose the nasopharynx, or you go beyond the soft palate from below. The soft palate can be split in the midline or split in the side. It depends whether you're going to treat a midline lesion or a laterally situated lesion. So mostly when we started with the nasopharynx, we started with this work using a midline palatal split. So the setup is exactly similar to what you do with the parapharyngeal space. You will use a Dingman retractor and a plastic cheek retractor, and then just split the palate at the midline all the way up to the hard palate level, and retract it laterally with stay stitches. And you can see this tumor is exposed immediately exposed. And it's enough room for you to do all the dissection. You can use a 0-degree scope or a 30-degree scope. And just at the conclusion of the procedure, you have to suture the palate carefully so that you don't end up with a palatal fistula. But then the problem is with the suturing of the palate, the patient needs to be put on tube feeding for 7 days to 14 days so that the palate wound is completely healed before they're allowed to eat. Otherwise, there is an increased risk of the breakdown of the suturing. And also, there are minor palatal retraction after due to the scarring, and some patients do have a little bit of vitopharyngeal incompetence after that. So this is the suturing. You see, we put the stitches one by one layer, and then at the end of the procedure, we put in a feeding tube. So this is a video showing what we're doing with the palatal split. This is done together with my colleague, Dr. Joseph Chung. I think he's in the audience today. So we split the palate, and you can see when you put in a scope, you get a magnified view compared to just using a headlight. And this is actually a small tumor up here. And you mark your index cuts with the robot. And then you dissect from inferior to superior. Now, the good thing with the robot is the magnification and also the traction countertraction that offers. It's not easy to do traction countertraction in a total endoscopic or endoscopic nasopharyngectomy because there's not a lot of room, and also it's very difficult without a wrist to hold the instruments and retract them in any direction. You can see we converge to the midline. We dissect from all four sides and converge to the middle to dissect it out. This is a really midline lesion, and we're not going to worry about the internal carotid artery. You can see at the top here is the clivus bone. There is no prevertebral muscle up here. So we dissect it off the clivus bone from the top. And you can see the robot gives you a lot of magnification and the dexterity from the wristed instrument. You can, of course, do it with an endoscope in a transnasally, but it doesn't really, my experience is it's smooth, easier to. Here we use a navigation system to try to see how far we are from the carotid. The navigation we use are the newer version of these navigation where the electromagnetic sensor is put at the pillow of the patient. So the patient is underneath the head of the patient, and you can see after the dissection there's a big hole space in the operating field, and we can obtain the foreign section margins with the robot. I'm just going with because with using the newer EM version where the sensor is put at the pillow. This is putting up with the nasoseptal flap. And the pillow, I mean, you can actually, the sensor, the navigation sensor will be the closest metal structure to the EM generator, and the accuracy is pretty accurate, even with the robot in place. So I just try to make sure this flap holds nicely with a suture. You can actually use a urinary catheter balloon inflated with water to pull out in place and without putting a suture. So this is the procedure, and then we just close it nicely. And this is the specimen, a 2 centimeter times 2 centimeter specimen. And this is another case showing that we do also a midline palate split, but this time the tumor is on the left. You can see there's a tumor on the edge of the fossa rosimolar on the right nasopharynx. This is a tumor, and we're just also resecting the tumor. This is a laterally based tumor together with the eustachian tube, cartilage, a cartilaginous eustachian tube. So after marking the resection margins, the first thing I do is I detach the pharyngobasilar fascia from the medial pterygoid plate. So the eustachian tube now is here, and I can able to grasp the anterior cushion of the eustachian tube and go to the parapharyngeal space. Now this is done in the older robot, the S robot, with the 5mm instruments, which I think is a much better instrument for doing any skull-based work, because it's a more gentle curve and it's smaller. But unfortunately, the XI machine doesn't have 5mm instruments, and it will be more clumsy and more difficult to access the lateral nasopharynx with the 8mm instruments. And with nowadays, we'll expect in the future, we're all going to be done by the new single port. It's a 6mm and a flexible snake instrument. So you see, I'm dividing the eustachian tube cartilage right around here, and then converging towards the here where in the middle where the tumor is. And finally, you can see the tumor is here, and I'm taking the tumor out and just switching to a scissors to obtain a bit of fluid section from the eustachian tube cartilage as a deep margin. And you can see the dexterity of the robot that offers. But sometimes you don't want to split the palate because there are actually some functional consequences doing that. And for some smaller tumors or other lesions that are not malignant lesions, you don't need to actually split the palate, but you can actually go beyond it. What we do is we just put 2 incisions on the upper part of the tonsils, which is very similar to what the sleep surgeons do for their layup procedures, and then use a suture to pull the soft palate anterior to increase the space here in the videopharyngeal region. And using a 30-degree scope, you can actually see the nasopharynx and actually use the robotic arms pointing upwards, and you can operate. So this is what I call the palatal suspension technique, and which is actually circumvents the problem with the palatal incision causing damages to the soft palate and the swallowing mechanism. So you can show you, and afterwards you suture it, and after 10 weeks, these just are fine. And actually, one of the benefit of this procedure is it reduces their snoring. So I'll show you a video. This is actually not a cancer, but actually a tumor in the parapharyngeal space or in the nasopharynx region. The eustachian tube is actually turns out to be a hamartoma on it. So you can see this is a tumor just anterior to the eustachian tube cartilage that we use a robot to remove that. So I put 2 stitches and pull the soft palate and uvula upwards, and then you go down. You can see the tumor here at the right parapharyngeal space region. And because this is a benign tumor, I don't need to resect the mucosa. I'm using a navigation just to make sure that where I place my incisions are correct. And I just incise the mucosa and the superior constrictor until I see the tumor. So this is very similar to what Suren was doing in his parapharyngeal space tumor, except this is a bit more superior, this tumor. So you can see with this technique, you can also do very superior based parapharyngeal space tumors. You can see a nice capsule. This tumor is a benign tumor. So we cut the pterygoid muscles. And with the robot, a lot of the dissections are very similar to what we do in open surgery. So we can do the blunt and sharp dissection. And you can retract the tissue and incise the muscle, and then use blunt dissection to dissect the tumor away from the soft tissue. So you see this is the tumor. And I'm using a navigation again to ascertain the internal carotid artery. And I just deliver the tumor now. It's a benign tumor, so it just, with a bit of blunt dissection, you can deliver the whole tumor out. And these are the parapharyngeal fat you can see. I'm just using a navigation. You can see the navigation probe coming in, and this is a navigation probe. I've just confirmed this is the internal carotid artery. which you're not supposed to expose it, leaving a bit of soft tissue to cover it. And for this case, I didn't suture. I didn't suture the mucosa. I just leave it behind and it just healed nicely. So this is showing the internal carotid artery. And then just put a bit of Surgicel to stop the bleeding from the venous, and this is the tumor. So finally, the problem with the bone instrument. Sometimes in some lesions, they involve the skull base, involve some of the upper clivus bone or the floor of the nasopharynx. For the, the floor of the sphenoid. For these lesions, usually what we do is a combined robotic and an endoscopic procedure. So basically, the inferior part of the dissection from the inferior part, we do all the way with the robot until we cannot do any further. Then we switch to an endoscopic resection of the anterior sphenoid wall and the sphenoid floor. So this is a lesion right here that we are able to dissect the inferior part using a robot all the way up to when we hit where it turns, where it turns 90 degrees at the floor of the sphenoid, and then we drill down all these with a conventional endoscopic skull-base approach, take down all the bone and drill a bit, and leaving behind, we excise the tumor and leaving behind the sphenoid all removed and the inferior part all dissected with a robot. So the robot just helps us to do the inferior dissection much quicker, although we can do it completely with an endoscope. So finally, I want to talk about how do we select our patients. The first thing is when you start with nasopharynx tumor, it's not an easy procedure. You should start with something small and central. And even if the robot allows you to go lateral, there are limitations. So I use the lateral pterygoid plate as a limit of how far lateral I can go. So this is the medial pterygoid plate on the scan. This is the lateral pterygoid plate. You can see this tumor. This tumor is just reaching the lateral pterygoid plate. It's really just at the maximum that I can resect with the robot transorally, because anything going more lateral, I will not be able to resect it en bloc because I have to go lateral to here and come down. So I have to do it with a piecemeal. So I would take the lateral pterygoid plate as my limit of the size of the tumor, and it should be a bit far away from the internal carotid artery. You can see this is the internal carotid artery. We try to be a bit beyond because we don't want to hit the carotid artery. It's a little bit more difficult for you to identify the internal carotid artery in the robot because we are not able to use our tactile sensation. Instead, we rely on visual identification of pulsation or the exposed carotid wall with the assistance of the navigation, although navigation may not completely be accurate because once you start your dissection and cutting in the tissue, the carotid can move because the tumor can be, if you pull on the tumor, the carotid can move medially and your navigation can be incorrect. And there should be minimum clivus invasion because if there is a close clivus invasion in the bone, we don't think that actually taking this tumor out with the clivus bone is actually oncologically sound. I don't think you can actually get a negative margin with that. The other, I mentioned before, you cannot just go lateral to that because your instruments will be beyond the reach once you go lateral to there. And you have to take it out in a piecemeal fashion, which I don't think is it's oncologically very safe because it's not easy to ascertain that you have actually complete removal of the tumor. Now this is the retropharyngeal lymph node that I would be a bit hesitant in doing a robotic surgery. You can see this lymph node has actually encased, or not encased, but abutted and maybe invaded on the carotid sheath here in the internal carotid artery. These tumors, invariably, they have been prior radiation and they are stuck. They're stuck on the carotid. It's very difficult for you to dissect, even in open surgery, to safely to protect the carotid. Not to mention if you try to use a robot instrument, which I don't think right now have the finesse of dissecting tumor off the carotid vessel as in open surgery. And also, if you have any vascular accident, it's very difficult for you to control the bleeding, even whatever we pack in, whatever. I would recommend these either if you're a very experienced skull-based surgeon using an skull-based approach, or if not, we still, most of the time, these lesions we like to using an open technique, where in case of a vascular catastrophe, we can actually try to control it either with finger putting on it or even try to suture the bleeding. So this is the same case, the retropharyngeal lymph node. Retropharyngeal lymph node, I don't have a lot of experience using a robot. I've done 1 or 2 cases, very scary. My colleague in Chinese University, Dr. Eddie Wong, had done 1 or 2 cases, also said very scary. The thing is, it's difficult to locate these lesions in the parapharyngeal space. And also there is a high chance of internal carotid artery injury. I would recommend at this stage, in the nasal pharynx, where you try to use a robot, I don't recommend it. Down in the oropharynx, the lower group of the retropharyngeal lymph node, it's easier because in the oropharynx you have more space. Once in the nasal pharynx, things become very narrow. And then finally, the patient factor. If the patient had trismus, if the patient had pharyngeal incompetence, you might not want to do this technique. If the patient, also some patients have the anatomy are not very favorable. The hard palate is very close to the posterior pharyngeal wall. Then you have a lot of room to do these operations. I recommend not to use this technique. And I'll spend the last minute talking about a little bit on the coverage. When we finish our operation, we have this nice cavities. Previously, we would like to just put a piece of mucosal graft on it, but we found that the take rate is pretty bad, and a lot of people end up with exposed bone and also radial necrosis. So nowadays, we almost always use a nasoseptal flap unless the tumor has eroded onto the pedicle of the nasoseptal flap that we cannot use it. We use a nasoseptal flap, usually the contralateral side, and put it onto to cover the nasopharynx while we wait for the throat section. And it allows us a very good healing. You can see once this exposed bone, once you put a nasoseptal flap, the inferior part will try to preserve the prevertebral muscle and not to expose the bone unless the muscle was invaded. Otherwise, it will allow you to have a very quick mucosalization of the cavity. And this is when we insert the flap, the same flap. After 6 weeks, you can see it's pretty much mucosalized. So finally, I had a little bit of experience using this robot, the Davinci SP, mainly on the cadaver. Also, we've done 2 cases of examination anesthesia using this robot. We don't have time today to talk about it. It was some of the time we talk about. Unfortunately, we don't have this robot with us right now. But this robot allows us to deploy transorally with a lot of ease. You can see this robot has 3 arms, and this robot has a flexible endoscope, which can be placed in the inferior part of the cannula or the superior part of the cannula. Depends on whether you want to operate down towards the larynx or you want to operate up to a parietal space and nasopharynx. So it allows us a lot of flexibility, and we can actually access the nasopharynx without actually splitting the robot. Because these arms are flexible, they can bend around the corner of the, you just have to do a palatal elevation, just kind of split the palate, just kind of pull the palate forward with stitches, and you can actually expose the nasopharynx. And you can see, this is the view what you get. The flexible rope endoscope allows us to flex in and expose the whole nasopharynx, and you can actually deploy all 3 arms. You can see this is the posterior end of voma, this is the nasal cavity inside, this is the posterior choana, the eustachian tube, the fossa rosumala all here allows you to do it. I mean, if we have cases that we need to operate like a chordoma, you can actually incise on the mucosa and operate on that with this robot. So I would like to, in the end, thank all the first Professor William Wei, who started the robotic nasopharyngectomy in Queen Mary Hospital, and also Dr. Joseph Zhong, my colleague that we do robotic surgery, and all our colleagues in the ENT head neck team in Queen Mary Hospital. My mentor, Chris Hosinger, which we do a lot of research, and also Dr. Jason Chen, my collaborator in Chinese University, where we did a lot of research on the robot. And thank you very much. And this is my email. If you have a question, you can please feel free to ask or email me. Thank you.
Thanks, Professor Sang. It's a wonderful presentation. A couple of questions. Do you suture the lateral palatal incisions that you make for a nasopharyngectomy?
You mean the palate incisions?
Yeah.
Yes, always. You have to suture it meticulously because otherwise you end up with a fistula. So I always suture it like this. After I split the palate, I actually suture it. And one more thing, because I detached the soft palate from the hard palate to allow me to retract the soft palate, I actually put 2 holes on the posterior end of the hard palate. and suture the hard palate mucosa back so that it doesn't detach from the soft palate doesn't detach from the hard palate.
So lot of these procedures are post radiation, post radiotherapy. Yes. So there the muscles would have got fibrosed, and the suturing would definitely be a challenge. You have any tips to overcome that?
Yeah, you're right. It's technically challenging, and I usually do it in 3 layers: the nasopharyngeal mucosa 1 layer, the muscle layer, and then the oropharyngeal side layer. And also, is you put all the stitches first, don't tie the knots, and then tie the knot. And after you put all the stitches, then you try to tie the knot. Because once you try to tie the knot, deep inside it's very difficult to suture.
Also, when you go laterally, you said your lateral boundary would be the lateral pterygoid plate. But how do you manage to drill down the medial pterygoid? The medial plate, the pterygoid, with the robotic, or because drills are not available, the robotic arms don't have the drill. Yeah. So what do you do?
I don't usually drill the medial pterygoid plate when I do robotic surgery. If I do endoscopic, I always drill it. But if I do robotic, I just incise the pharyngobasilar fascia right where you attach the medial pterygoid plate. And because the robot has a wristed instrument, I can then go lateral and go into the parapharyngeal space and come back forward to remove the whole fossa rossomolar out. So I don't usually drill. If I need to drill it, I have to bring in an endoscopic drill and drill down this plate. You don't need to, but you can drill it. It gives you more room for you to operate. But still, going beyond the lateral pterygoid plate is a bit risky because it really is at the really far reach of the robot.
Right. Also, any experience with robotic excision of retromaxillary lesions?
Unfortunately, no, I don't. If I have to do any retromaxillary lesion, I do a conventional endoscopic approach, a transantral, doing a transantrally from the endoscope. I haven't had an experience doing this approach because I find it too cumbersome with a lot of bone work. But I think theoretically you can with this approach, and then you drill down all the bone here. You can use a robot to remove any lesion in the infratemporal fossa.
Also, when you do nasopharyngectomies, do you also do retropharyngeal lymph node dissection as a standard, or do you limit it only when there's a node there?
Good question. For all our nasopharyngectomies, there are recurrent there are post-radiation recurrences. So except for the benign disease. So we don't do the lymph node dissection unless the lymph node is involved when we shown on the PET scan or the MRI. So it's not a routine to do a retropharyngeal lymph node dissection. And actually, I think it's still quite dangerous because the lymph node will be stuck on the carotid sheath, and it's a very fibrotic lesion, and it's not easy to dissect the plane off, especially with a 5 millimeter with 8 millimeter robot. The instruments are actually still quite bulky, so it's not easy to dissect it off from here. So we don't usually do a lymph node dissection, retropharyngeal lymph node dissection.
Okay. Thank you, Dr. Sang, for that. We move on to the next presentation by Professor Tae from Seoul, South Korea. We'll be presenting a surgical video on transoral robotic thyroidectomy with INOM.
Yeah, hi, good afternoon, all four professors and colleagues and friends. And thank you for inviting me to this wonderful online meeting. And can you see my slide? See my video?
Yes.
Yes. Today I would like to show you a video clips of a transoral robotic thyroidectomy with intraoperative neural monitoring. This video is just accepted for publication in the video endocrinology. The learning time is about 8 minutes. I hope you enjoy the video clips. Transoral thyroidectomy has gained popularity owing to the superior cosmetic result and low morbidity. Transoral endoscopic thyroidectomy is more commonly performed than the robotic procedures. However, The trans-robotic procedure has advantages such as a three-dimensional magnified view, innovative instrumentation, and the ability to use 3 robotic instruments for obtaining counter traction. Intraoperative neural monitoring is useful for identifying and confirming the nerve in another working space and the limited surgical view of transverse thyroidectomy. We routinely perform the neural monitoring of the Laryngeal nerve and the external branch of superior laryngeal nerve, obtaining the V1, S1, S2, R1, R2, V2 signals. The operation is performed under general anesthesia with orotracheal intubation. The neck is extended with a shoulder pillow. The proper position of the EMD tube is important, and the position of the tube is routinely checked after intubation and the neck extension using laryngeal fibroscopy. The robotic instrument itself is used as a stimulating to the neural monitoring system using the custom-made cable. After the central mucosal incision near the base of the lower frenulum, dissection is performed over the periosteum of the mandible and extended to the submental area using monopolar electrocautery and clamps. Blunt dissection of the submental area is performed with the Haga dilator in the midline and on both sides of the midline in a fan-like shape. A 12 millimeters trocar is inserted, and the carbon dioxide insufflated at a pressure of 5 millimeters of mercury. A lateral mucosal incision is made close to the oral commissure to avoid injuring the mental lobe, and the dilated epinephrine is injected over the periosteum of the mandible for hydrodissections. The robotic trocar is inserted through the lateral incision. After inserting the 3 oral trocars, the exact plane of the subplatysmal layer is identified in the submental area. A skin flap is elevated through the plane of the subplatysmal layer using laparoscopic dissectors and the hook bobby. The Davinci SI surgical system is placed in the duct on the left lateral side of the patient. A 30-degree endoscope is placed at the center, and the monopolar scissors and the Maryland forceps are placed on either side of the endoscope. After docking the Davinci robot, the elevation of the skin flap is extended inferiorly to the level of the sternal arch and laterally to the midline of the sternocleidomastoid muscle. Using a surgical robot is convenient for raising the skin flap compared to the endoscopic procedure. After creating in a working space, a 1 centimeter incision is made in the right axial fossa, and a long robotic cannula is inserted into the working space. A further robotic instrument is inserted through the axial port for counter traction. The midline fascia between the strap muscles is divided. And the sternohyoid and the sternothyroid muscles are dissected to expose the thyroid glands. The middle thyroid vein is divided. The VN signal is obtained by stimulating the vagus nerve bluntly in the carotid sheath. The pyramidal lobe is dissected. And isthmus is divided and dissected from the trachea for better mobilization of the thyroid glands. The external branch of the superior laryngeal nerve is identified near the laryngeal insertion portion of the sternothyroid muscle. The superior thyroid vessels are divided close to the thyroid glands. The S2 signal is obtained and the integrated nerve is confirmed again. The superior parathyroid gland is identified and carefully preserved with an intact blood supply. The thyroid gland is then retracted medially, and the dissection is continued to the ligamentary very area. The recurrent laryngeal nerve is identified. The perithyroidal soft tissue is dissected while tracing the recurrent laryngeal nerve. The resected specimen is extracted in a plastic bag through the axillary port. It is convenient to take out a large specimen through the axillary port compared to the oral vestibular port. The R2 signal is obtained. V2 signal is also obtained. The strap muscles are reapproximated using V-lock suture. No drain is placed. The oral vestibular mucosal incision and axillary incision are closed, and the operation is completed. Thank you for your attention. Thank you. This is the end of the video, yes.
Professor Tate, do you have another video? Or can we take the questions?
Yes, yeah, I'm ready.
Could you please tell us more about the nerve monitoring? Could you see the probe we use normally? When open ear, there's a separate probe, and I believe you had shown it initially in the video as well. So you use the additional cable to connect it to the monopolar artery. If you could just give a little more details to the audience on that.
Yeah, so actually, we can use several types of the stimulating probe in the endoscopic robotic transverse thyroidectomy. And typically, the short types of standard types of neuromonitoring stimulating probe is not available for this procedure. So if we can use the long lengths of a stimulating probe, or as you can see my slide, it is very convenient if we use the stimulation, the robotic instrument itself as stimulation probe. It's just connected by the cable to the neuromonitoring machine. It's very convenient. So you can use the neuromonitoring, nerve monitoring as either as a monopolar seizures or as a bipolar seizure, whatever, if you want to. Yeah. Another type is you can use the small small tips ground the needle and hold it and stimulate it directly the nerve. Yeah, you can use this one of option.
So coming to the port placement, so here you demonstrated left hemithyroidectomy. The arm 1 comes from the intraoral and the arm 2 through the right axilla.
Yes.
So does it remain the same when you're performing total thyroidectomy as well?
Of course, it's same as well. As actually due to the position of Davinci, I'm using the Davinci SI surgical system. So we need to place it to left lateral side of patient. So usually we can make right axial port, extra port. So it is more convenient to approach the left side lobectomy case. But in the right side lobectomy case, also we can use the right axial port. But sometimes you can use only three loboric arms through the oral cavity without additional axial port.
Professor, how easy is the docking with the the XI system or the SI system with the gasless technique?
Yes, actually, we can use the SI or XI model. XI system is the booming is the arm is boomed over the head, so XI system is more convenient. But SI system also you can use it. Also, some speakers in Korea, South Korea, developed some gaseous transfer oral approach. But I don't support the gaseous transfer approach, because for the gaseous method we need more wide dissection of the premandibular area, submental area. So it causes some damage to the submental. I mean the mental nerve. So I prefer the short gas insufflation method. Yeah.
Right. So what are your determinants to assess a patient's suitability for transoral robotic thyroidectomy?
Pardon again?
So what are the criteria that you look in a patient for transoral thyroidectomy?
The indication might be expanded according to the experience of surgeon. In my experience, we can apply to T1 or T2 cancers. Also, size is one of a barrier of a transfer approach, because if tumor is very large, it is very difficult to take out the specimen through the small transoral route. So in this case, if you use axial port, it is more convenient to take out larger specimen. In terms of size criteria, I would recommend the ideal indications of transoral approach is less than 3 centimeters.
Also, Korea is one of the very few installations for the single port system as well. Have you had any experience of using the single port?
Unfortunately, I have no experience as a Singapore system, but the Singapore system these days is the cannula size is 2.5 centimeters. I think it is too big, too large for the transfer approach. To place this 2.5 centimeter cannula, we need more wide dissection in the submandibular area. Submental area is about 2 or 3 centimeters. So it causes soft tissue damage, also it causes mental damage.
So there's another question as to when you place the axillary port, what instrument do you use?
No special instruments, just making small incision, and you can insert the long robotic or endoscopic trocars. It's very simple. Also, it's not too much invasive. Yeah.
Right. Thank you for that wonderful demonstration of the technique. We'll move forward to the next talk. Thank you, Professor.
Thank you.
So the next talk is by Professor Awang from Thailand, who will be talking on transoral endoscopic thyroidectomies.
Okay. Thank you so much for allowing me to present my work in this wonderful webinar. So right now we're talking about my transoral endoscopic thrombectomy. So I will use the share screen. Let me do a share screen first. Okay. Okay. Can you see my slide? I think
Yes,
it's short.
yes.
Okay. So right now we focus on my transoral endoscopic thrombectomy. It is not the robot, but this is the beginning of the robot. I think I will share my perspective of the tip and trick for the beginner. Okay, back to the future. 6 years ago, this is my first case when the history began of the transoral endoscopic thrombectomy. This lady is about 45 years old. I did the first case on that time on 31st March 2014 with 2 cm of the right thyroid nodule. The uptime is around 2 hours. This is the first case, and when I successfully did this case, I have my story on Thai newspaper at that time, and of course also around the world. And I think 6 years from that time, not 5 years, 6 years, around 6 years. So I did around 2,000 cases, which can be divided into the thyroidectomy as well as the parathyroidectomy. So we do all of the lobectomy and the cancer as well, and the Graves' disease as well. So this is my first paper on that time. I think the first paper on the World Journal of Surgery described about the TOEDVA, Transoral Endoscopic Thrombectomy Vesicular Approach. This is the first 60 human cases. You may read about this already. And this is another parathyroid cases reported in the surgical endoscopy, and 6 hyperparathyroid, and about the primary, and 6 cases of the renal hyperparathyroidism that time. And this is the largest series published on in the JAMA surgery, comparing about, I think, comparing the TOEDVA with the open thrombectomy group. So right now, when you search the terms transoral endoscopic thrombectomy on PubMed, you may find it right now. I think it's around 200 right now, and you can see that the trend is increasing by year. And this year, I think there are about 46 publications since January, maybe slowly progress a little bit because of the COVID pandemic. I can see that right now is around 41 countries that can do this transoral endoscopic thrombectomy vestibular approach with endoscopic thrombectomy. So you can see that the list of the country they can do this procedure. So 6 years past, what changed of my first technique and comparing to this technique in present day. So indications changed a little bit. So this is my current patient selection criteria. It would be the benign, maybe nodule cyst, or well-controlled Graves' disease. So the recommended thyroid lobe size is around less than 7 centimeters. You can do AUS, follicular hyperplasm, and right now I do in the thyroid cancer as well, but choose only papillary or follicular cancer with the cancer nodule less than 2 or 3 cm. For this is my selection criteria. So this is absolute contraindication. If the patients had the lateral neck lymph node metastasis, no, you cannot do this. Subsonal goiter, distant metastasis, adjacent organ involvement, for example, esophagus or trachea, medullary thyroid cancer, uncontrolled Graves' disease. So this is an absolute contraindication. Well, for the beginner, this is my suggestion for the beginner. Because maybe in first 1 to 10 cases, you have to choose around this criteria. First one, you have to do in benign thyroid nodule only. The second one, less than 2 or 3 cm nodule. If you are right hand dominant, so please select right side thyroid, will be convenient for you. You must choose female, the age around more than 40 years old patient. This is perfect because her skin will be loose enough for you to making the space creation, and no thyroiditis, no Graves' disease, no toxic or no cancer. Well, this is for my suggestion for beginner. If you pass the learning curve, let's say 10 to 15 cases, you can move on to other difficult criteria, for example, Graves' disease or left side or something like that. This is my own incision. When I first started this procedure, you can see that I did only 10 millimeter at the center, and you can see that the bilateral 5 mm port is here, is at the center of the buccal cavities over here, aurovesical cavity. So you can see that the yellow dots here refer to mental foramen, which give 4 branches of the mental nerve. My first incision may make some injury to the mental nerve here. This is a problem on that time. And for example, the most important is that if you make only 1 cm here at the center, you will have some difficulties in removing the specimen from the center incision here. So that's why I refine my, I will show my video first. This is my own incision. You may find this on YouTube as well when I post on YouTube about my first technique. You can see that the 5 mm port is here at the center. Well, I would say that this is not a good incision anymore. Sorry. Sorry, I did. Okay. Okay. Well, this is the new incision. So I decided to refine my my port incision because of that problem, mental nerve injury, and very difficult to extract the specimen. This is incision, and I did until now. The first incision here is about 2.5 centimeter at the center, just above the frenulum. And I moved the incision from here, from the center of the vestibular approach to just underneath the lower lips. You can see that when you move from here to here, the chance of the mental nerve injury is very low. So you can see that this is my current incision. Made the incision here, use the Bowie to coloring a little bit around to pass the tip of the chin, and I use the Kelly clamp to pass the chin and make some dilatation by Kelly clamp, and then insert the 10 mm port inside. And then for the lateral, I decided to move from here to here, just underneath the lower lip bilateral side. Bilateral side. Okay, so when we finish port insertion, you can see that the picture will be like this. This is the center incision, center port, and bilateral trocars 5 mm here. Please note that please use the very small housing, low profile of the bilateral trocar, because of when you move your instrument bilaterally. So if you have the big trocar, just like from Johnson & Johnson or from Medtronic, so the housing of this bilateral trocar will make some collision and make you difficult to move and operate. So you can see the linings of the ports will be over here. And I proved this concept by dissecting in the cadaver. You can see that this is the mental nerve. This is the mental nerve, and you can see that the lateral trocar is just underneath the lower lips. So the chance of main branch mental nerve injury is very low right now. So there are some papers from, I think this is from Taiwan. They proved my concept as well. So we agree that move the incision from here, from the center to up and lateral, just underneath the lower lip, is the best way to avoid the mental nerve injury. This is the same conclusion. So then you plug in 3 ports already. So this is the endoscope view. You can see that this is a hole from the later, and all you have to do is just try to disconnect this septum, I mean the fat, and make a hole, just like a tunnel, just big tunnel inside. So this is strap muscle down here. This is the platysma muscle, and this is a hole made by the lateral. You can choose the hook, you can use the harmonic or whatever instrument. And then you can see that this is the thyroid. So he is trying to dissect just above the strap muscle. So, and then if you have the big space enough, the rest is that you have to open the midline using the L hook, or you can use the harmonic or whatever instrument, energy-based energy device. Please remember that if you use the L hook, please cut a very shallow cut, because if you cut too deep, you may cut to thyroid or even trachea. And then the next key or the next landmark you have to find is that this is the cricoid cartilage. This is the first landmark. And then you have to cut all the way down to the sternal notch. Because this TROEDVA or transverse endoscopic thyroidectomy, you may sit above, you may stand above the head of the patient. So it's just like you look from here to here, from the mouth to the sternal notch. You may see endoscopically view just like this. This is the cricoid cartilage. This is the thyroid isthmus. This is the trachea and sternal notch. So you will see the view like this. You can see that in my experience, I found 4 cases of the right side non-recurrent laryngeal nerve. You can see that this is the right side non-recurrent laryngeal nerve. So be careful when you operate, because sometimes some surgeons, they don't want to dissect for the recurrent laryngeal nerve. This may be happening as well. This is another example of non-recurrent laryngeal nerve. I will show the video of the operation later, no worry. From the external branch, can we see it? Oh, I would say that this is the same as open thyroidectomy, is not always in. But if you really want to see it, you have to cut the sternothyroid muscle here. You can see it, but you have to cut this muscle. This sternothyroid muscle tend to insert just like this. So I cut only the muscle here, and you may find that this is the cricoid cartilage. This is the right thyroid. This is the superior pole. This is the jaw space or cricothyroid space. The external branch of the superior laryngeal nerve usually goes with this way and make a U-turn and insert into the cricothyroid muscles over here. So all you have to do is just you can make dissections over here, push the nerve down here, and then you cut the superior pole. This is the right side external branch. And this is the left side external branch. Is the same story. You can see that it will make a U-turn here into the cricoid cartilage. You can use the nerve monitor to test this nerve as well. So avoid the heat transfer from energy-based device. Even you can use harmonic, or even you can use the ligature as well. This is the ligature Maryland from Medtronic. You can see that there are some heat radiated from this active blade. We call it active blade. So even harmonic or ligature, they will have the heat transfer. The company always claims that the heat transfer from the tip is only 1 mm for the ligature, and harmonic, they claim that 2 mm. But from this study, if you search from PubMed, they claim that okay, ligature is 1 mm and harmonic is 3 mm. But in the reality, I think you guys maybe experience this as well. I think the safety margin from the heat transfer is 4 mm, 3 to 4 mm. It means that you have to put this active blade or the tip of the ligature away from the nerve at least 4 mm to prevent the nerve injury or the heat transfer to the nerve. Or you can use the nerve monitor. So in Thailand, we have only Medtronics. We use the NIM trees. I think this is my recommendation to use the NIMs in the nerve monitor for all cases, because of it is not only to confirm the recurrent laryngeal nerve, but you can stimulate the external branch as well. Or you can trace the recurrent laryngeal nerve course and direction of the nerve into the insertion. This is very useful, and especially for the beginner, you have to do it. So I have some example video. You can see that this is the right thyroid. You can see that this may be parathyroid. And where is the nerve? I'm not sure, maybe here or maybe here or maybe here. So I plug in the nerve monitor, and you can see that the amplitude is here. So this is the example how to trace for the nerve course, and above here is not the nerve. So the next step, I can cut above it. I can cut the non-nerve attachment to be confirmed that this is not the nerve. So you can see the usefulness of this, because you guys are changing from open thyroidectomy to this transoral. You change your point of view in order to finding the nerve. So nerve monitor is very important. So when you use nerve monitor, you can use the orotracheal intubation, just like here, or you can use the nasotracheal intubation. But if you use nasotracheal intubation, you have to maybe cut some the tube. I mean the beginning of the tube with the nasal ray, and you can have the long enough the tube and space, because sometimes if you use orotracheal intubation, your left hand, for example, in these patients, they put the orotracheal into your left ankle of the mouth, your left hand maybe have a little bit struggle. So for me, I prefer to use the nasotracheal intubation, just like this picture. About the nerve probe, you have 3 options. The first option, you can have the commercial probe from Medtronic itself, is around maybe 28 centimeters long ball tip probe. But the disadvantage of this ball tip is that because of this radiated signal, I mean the electricity around 360 degrees, that's why it has some difficulty to trace the nerve and to precise to finding the nerve. This is the disadvantage of the commercial probe. You can have option 2. I think this is Korean concept, just like Professor Tay talked about, because I use the this is connect to the outhook or Maryland. You can use it, and this is connect to NIMS panel. You can use the wire from the electricity. And cut and connect it together, connected with the NIMS together. And this is custom wire Korean concept. You can use this as well, and you can change to this end. You can connect to outhook or Maryland or whatever you want. Or you can have option 3, if you don't want to cut the wire and connect together because of your hospital maybe not allowed to use this. So you can use the open probe, just like open probe from NIMS for open thrombectomy, and you can use the outhook from COMeD and Valor Lab. You can see that this is just for the normal the laparoscopic set from Valor Lab, or basically is the same company right now. You can remove this part and connect into this part, so it will fit together completely. And this is another idea. And about the specimen removal, you can see that you have to use the endo bag. Endo bag is very important because you may not want this thyroid to crack or open or break when you try to remove from the chin, because if this tissue is cancer, maybe it's implant to the tip of the chin, is not a good idea. So endo bag is mandatory. You have to use it. Key is to use the push and pull technique. It means that you can have to use your left hand to push the specimen just below the chin here, and while your right hand, you have to use the grasper to grab this thyroid inside and try to pull. We call this push and pull technique. You can remove maybe 3 or 4 cm out of the central incision very well. Okay, for me right now, for me, if the thyroid gland is less than 5 cm, I prefer to move from the oral cavity. But if the thyroid gland is greater than 5 cm, you have 2 options. The first option is to remove from the axilla. You can make another incision in the axilla, insert the port, make some dilatation, and pull this greater than 5 cm thyroid size through the axilla. Or another option, you have to cut the specimen inside the bag and remove from oral cavity. But this is maybe not good for some circumstance. For example, a very big and single solid nodule 5 cm, and you don't want to break it. You want to break it. So I think if the nodule is trained to be solid and it looks like cancer or something like that, you have to move from axilla. So I will show my video from the start when I plug my 3 ports inside. So the first step is to create the space using the L hook. You can see that I use the L hook to cut the space between platysma muscle above, and this is the strap muscle. And you can see that this is a midline, and the thyroid is underneath this strap muscle. This is the left clavicle. This is the left SCM. This is sternal notch. This is the right clavicle. This is the right SCM. So you can see that this is a midline, and I will use the L hook to open this midline layer by layer. So do not cut it too deep because you may injure to the thyroid or the trachea itself. So gently and slowly cut it, and then you have to file for the cricoid cartilage. When you file the cricoid cartilage, just cut it back down to sternal notch to open it as much as possible to access the real capsule of the thyroid. This is an isthmus. You can see that this is thyroid tumor. And then because I'm going to do the right thyroidectomy in this case, the next step is to peel off the strap muscle, especially sternothyroid from the thyroid capsule as much as possible. You can see that this is sternothyroid inserted here. So this is the middle thyroid vein. You can see that this is thyroid lobe. Try to get access until you find the carotid arteries over here. Because we are not using the nerve monitor, that's why expose the carotid artery is very important. Because we don't have the retractor, just like open thyroidectomy, we don't have assistant to pull the retractor. That's why I will introduce the silk 2O, silk number 2, and from outside and cross around this strap muscle and go out again and let my assistant to pull this. You can see we have more room, plenty of room to dissect. So we inserted it, and then we find the carotid artery and test the signal for the V1 signal. And this is the vagus signal. You can see that. And then we go back to the center, just above the cricoid cartilage, and try to get access into this vascular plane between trachea and the thyroid isthmus. You can see that this is a plane, very nice plane, a vascular plane. And this is the isthmus. So we cut the isthmus first by cutting close to the left thyroid. The smoke will be produced like this. So you have to open the valve all the time to let the smoke coming out. And then you can see that this is a tracheal ring. After complete the isthmusectomy, you have to get access into the superior pole. This is a superior pole. I will usually try to dissect for the jaw space or control thyroid space. This is a vascular space as well. And you can use the left hand to grasp the whole superior pole and lift up to other side, and then go over and over and try to pull to pull the superior pole upward as much as possible. And then you cut the suprathyroid artery. Sometimes you may find some external branch over here, but in this case we don't have to do it because it's very located very deep. And then we search for parathyroid. When we find it and we push it down, and then we find the nerve. This may be a parathyroid. So it's time to find the nerve. I imagine that maybe this is the nerve, recurrent laryngeal nerve. This is a circle candle. So I use the nerve monitor to trace for nerve cause, as I told you earlier. Above here is no signal. That's why we can cut above here, close to the trachea. So 4 mm is the safety margin away from the nerve, as I told you, and then we cut it all the way down to sternal notch to complete the lobectomy in this case. And then endobag is mandatory, as I told you. You have to use it in every cases and dunk the specimen inside the bag because this gland is less than 5 cm. So, and it's very soft. I think it can remove it from the center incision without making any axial incision, and then remove from it, but do not pull it purely. Please use the sponge forceps and grab the thyroid inside the bag and push and pull technique. You can see my left hand is pushing, my right hand is pulling, push and pull technique. Okay, and then check for the bleeding. You can see that this is a nerve and this is a vessel, it's not the nerve. So we confirm again. This is a R2 signal. And lastly, for the V2 signal at the lateral of the carotid. And no drain Right now, I put no drain, and I use the V-lock to making a suture of the strap muscle. This is the last step, and then we will move the part out and close the oral cavity by two layers: the muscle inside and the mucosal later. So normally I have the International Thyroid Node Conference. This is the first time arranged in 2016 in Bangkok, Thailand, and then we have the second course with more than first time attendance with cadaver dissection as well. And the third and the fourth has arranged every year. But this year we tend to have it on May, but the COVID appeared, the pandemic. So I postponed to October 2020. But my feeling right now, I cannot make it this year. I think because of the pandemic is not, I think they might resolve at all. Maybe the fifth time, maybe postponed to next year. I will tell you guys later if you're interested. Please go to the transoras.org for the website if you're interested in join this conference. Thank you very much.
Thank you, Dr. Awang. That was a interesting presentation. So when performing total thyroidectomies, do you always divide the isthmus?
Yes. For it depends on case by case. For open thyroidectomy, right now I perform the isthmus as well if I do the lobectomy. But if I perform the total, no, you have to do left and right together. No need to cut the isthmus.
But then the approach that you would be taking, that is through the midline and then going laterally, will that be an impediment without dividing the isthmus?
Sorry, again?
So the approach that you demonstrated in the video goes from the medial to the lateral. So yeah, so without dividing the isthmus, would it be possible to do a total thyroidectomy?
Yeah, yes, you can do it as well. You can do it, but in my feeling is if we cut the isthmus first, when we mobilize the superior port, it will be easier. It will be easier.
Right. Also, when using intraoperative nerve monitoring, muscle relaxants are not generally given by the anesthetist. So, has there been a challenge for you with the space, the retractions, and though you use a gas technique, would it be? Has it been a problem which you have felt? The relaxation.
No, not any problem anymore. So you can use non-relaxant sedative as well. It's not a problem. You can do it.
Also, how do you? So which endoscope do you use, and do you use an endoscope holder to get a better stability?
So I use my resident or my fellow for holding my scope, and I usually use the 30 degree 10 mm scope because of the benefit of 30 degree. We can see just like top down view like this. If you use 0 degree, you will be difficulty finding the nerve because you cannot see it down there. So 30 degrees is the best right now, I think.
Right. Any so the complications like post-operative bleeds, have you had any, and how did you manage if there were any?
Well, I do have 3 cases of the post-op bleeding, but that case occurred 2 or 3 days after operation, maybe from minor bleeding from the muscle. But the patients tend to have not a good condition. That's why I have to open her neck. But if the patients have the bleeding, maybe just post-op bleeding 24 hours, so you can put in the same port. And I heard some story from my colleagues as well. They have 24 hours, less than 24-hour bleeding. So they put everything into the same route, just like put the 3 port and make a suction. And by the way, I think it depends on the patient's condition. If the patient condition is first, so you may go for the open. That is the best for the patient.
Yeah. Also, you elegantly described the tips for a young beginner to start off the case selections. But any particular tips, or how do you consent a patient to take up this procedure, the transoral endoscopic procedure?
Oh yes. I tell the truth to the patient. For example, when I first want to do this, I tell the patient the truth, but I will tell them that I trained for this. I went to see other surgeons or at a foreign country, but I never do this in Thailand. I train with the cadaver. Well, we have the form, the consent form describe everything. For example, indications, disadvantage, the worst thing, the complication might occur, but we have to. I think that the first difficulty, the very difficulty for us to obtain the patient, the first patient, is that we have to tell patient the truth. So I think it might take, I can't remember that. I think it took me 3 months to find the first case. But when the first case we did completely, we have the reference to show now to patients.
Right. Thank you, Dr. Awang. It's a great presentation. So we would be winding up the first session of the day. But before we do that, we could have the closing comments from all the speakers. We have unmuted you, and your videos are up. So if you could just come over to give the closing comments and discuss additional points which we couldn't cover in the first session, the questions which were unanswered.
Okay.
We can start with Kaustubh, sir.
Yes, this was an excellent session. I was really thrilled for seeing the beginning. As we, in Shahrukh Khan says, "Ye to trailer hai, picture abhi baki hai." So I'm sure that next 3 sessions are going to be really, really interesting, and I look forward to all the 3 sessions, today 1 and next 2 on next Sunday. Thank you, all the international and national speakers, and even the delegates were, quite interactive. We got a lot of chat questions and enjoyed, interacting with all. Thank you.
Dr. Sang, any comments from your end?
Well, yes, thanks very much. It's been a wonderful Sunday afternoon for us. I just let everyone know, somebody asked about using a navigation robot. I left one of the publication I did, the techniques, I left it on the chat. I had to actually, if you go to the chat, I actually left the publication that you can go and laryngoscope that you can go and see. I mean, and individually, if you need any questions, you're happy to email me. I mean, sometimes it's a bit difficult to answer all the questions in the same time in the webinar.
Right. Thank you, Professor Sang. So I think any comments from Professor Tay?
I really enjoyed this conference. Yeah, yeah, it's a big success, and we need a continuous kind of this types of conference futures. Also, Trans-Robotic Approach is a kind of a modern change of in the remote access thyroidectomy. So we can develop more techniques, and if you develop more robotic system, we can further develop these techniques. And if you have any questions, just email me. I would like to discuss with you for further details. Thank you.
Thank you. So for all the participants, so any specific questions that you would want to put up to the speakers, you can write into us at our email ID, and we would try and respond back to the questions separately. Thank you all. Thank you. We would catch up again in the evening for the next session, which would be even more interesting on a different note altogether. Thank you, everyone.
Bye.
Thank you.
Bye.